Good afternoon, ladies and gentlemen. Welcome to the ICOG Masterclass on the 10th of February 2023. And this year has been full of ICOG programs. And as you know, we have been seeing that Dr. Lakshmi Shrikande, our chairperson of ICOG, has been bombarding us with programs, and we are actually stumped with the amount of programs which ICOG is going through this tenure. And yet another addition is going to be the masterclass of ICOG today. And this is going to be a special topic, and that is going to be saying as laparoscope and hysteroscope, a ray of hope, and that is what the topic is going to be about today. And we will have 6 experts speak about different topics in that. And as you could see, the program has been absolutely marvelous, and we have extremely enigmatic speakers speaking to you on these 6 topics. And before we start the topic, let me request Dr. Lakshmi Shrikande, our chairperson of ICOG, to welcome you all. And before that, with the blessings of Dr. Rishikesh Pai, a FOGSI president, absolutely energetic, we are going through this particular program. And let me request Dr. Lakshmi Shrikande to welcome you all. Over to you, Dr. Lakshmi.
Thank you, Palani. And I fully agree that today's program is indeed a marvelous one. I always wonder, when all the urologists, they can't think of doing their practice without cystoscopy, how come we gynecologists are still lacking, and so many gynecologists, they don't know how to do diagnostic hysteroscopy. So I'm very happy that you have come out with this masterclass, and full session is on hysteroscopy. I'm waiting for the day when hysteroscope will become our another extended arm, like TVS has already become. And we understand that laparoscopy is much a bit tricky than hysteroscopy, but I think at least each and every gynec should be able to do level 1 laparoscopy. So I'm very happy with today's topics and speakers, and I really hope that after this masterclass, we will be able to motivate our gynec fraternity to indeed start doing hysteroscopy and laparoscopy on their own. So I welcome all the speakers and chairpersons, and of course, Palani, you are doing a great job for conducting this obstetrics and gynec masterclass. And I also welcome Parag, who is our vice chair, and all the delegates. So I hand over back to Palani for further proceedings.
Thank you, Dr. Lakshmi. And we go on to the program straight. And we have Dr. Parag with us, who was actually logged in much before any of us giving instructions, just as how Parag could be. And Parag can't sit his chair off when an ICOG program is going on. That shows the amount of commitment Parag has towards the program. And let me just move on to the chairpersons of today. And we have 3 chairpersons today. And of course, the first one of them, being none other than Dr. Parag Biniwali himself, and he's the vice chair of ICOG. And I'm sure this platform doesn't need any detailed introduction of Dr. Parag, because there's nobody who could not know Dr. Parag, and he will be the chairperson for this particular session from Pune itself. The next chairperson I'm not able to see is Dr. Sushila Rani. Dr. Sushila Rani is from Bengaluru, and we saw her being quite active both in ICOG and in the All India Conference of Bengaluru, and quite a nice friend of all of us. And I only wish Dr. Sushila logs in quite fast. I'm just going to call her as such. And then the third chairperson is Dr. Pratik Tambe from Mumbai, who's a very active governing council member of ICOG along with me, and absolutely scientific and academic. And over to you, 3 chairpersons, to take over the session and go on and proceed with the first session, that is the hysteroscope. Over to you, chairpersons.
Thank you, Palani. Good evening, all. I bring greetings from ICOG, and it's indeed a pleasure to be welcoming you today for the masterclass. And today's masterclass is on laparoscopy and hysteroscopy, which are so important armamentarium in a gynecologist kitty. First of all, thank you, Lakshmi, for conceptualizing the masterclass, and thank you, Palani, for executing it. The faculty that you've chosen is probably few of the best lot who will actually teach our delegates today. So without wasting time, I would first like to invite the first speaker, and that is Vanita. Vanita is a medical director at the Sunrise Laparoscopic Center. She's a teaching faculty at EISC Chennai. She's the managing council member of OGSSI. Over to you, Vanita.
Thank you, sir, for the kind introduction. At the outset, I thank ICOG for having given me an opportunity to be a part of this masterclass, and an extremely happy feeling to be amongst the stalwarts of gynae and endoscopy today. Question given to me by the convener today is, should we treat all uterine polyps? These are the common types of polyps that we encounter in our day-to-day practice. Are we going to treat them? Yes or no is the answer that we're going to get over the next 20 minutes. If we are going to treat, are we going to do a hysteroscopy? Are we going to do all the polyps? Let's try and find quick answers to this. A quick look through of what uterine polyps are. They localize intrauterine overgrowths of endometrial glands and floma, which project from the endometrium. They could present with a vascular stalk and be pedunculated or sessile. They could be either single or multiple. The general incidence is around 7.8 to 41% in women, occurs both premenopausally and postmenopausally. The commonest age group is between 40 to 49. However, it's rare in less than 20 years of age. When it comes to the size, it can be anything between small ones, which are around 5 millimeters, to large ones, which can fill the entire cavity. Women who are at risk for developing a polyp are the ones who are hyperestrogenic, like our PCOS patients and patients who use tamoxifen for breast cancer treatment, and women who have HRT with the intact uterus. And again, diabetes and obesity also predispose to getting a polyp. Signs and symptoms. When we look at polyps, most of them are asymptomatic. However, a proportion of the patients can present with heavy menstrual bleeding, intermenstrual bleeding, postcoital bleed if it extends till the cervix, infertility and RPL. If you see the incidence of polyps in patients worked up for fertility is definitely more compared to the general population. Occasionally, we could have pain abdomen, malignancy, and abnormal vaginal discharge as a presenting symptoms. Diagnostic modalities. A simple transvaginal ultrasound is good enough to pick up a focal endometrial lesion which shows up and as a cavitary lesion, ICOG with the endometrium. When you see something like this, immediately turn on the Doppler. Once you see the color Doppler and you see a vessel there, you know it is definitely a uterine polyp. A 3D ultrasound can give you some more clarity. And the best way to differentiate it from the other lesion which you suspect is the myoma is to push in saline. And this is the image which you would do when you get the saline sonography done for a polyp. Hysteroscopy is not just a diagnostic modality in today's era. When you put in a hysteroscope, we are in a scenario there. We need to diagnose and also treat at the same sitting. And always better to do the ultrasound in the proliferative phase because the polyp stands around better compared to the later half when the endometrium is also thickened. Looking at the clinical course of polyps, they are mostly benign. The prevalence of atypia and malignancy is around 0.8 and 0.1% respectively. However, the risk of malignancy in postmenopausal women is around 2 to 4%, slightly higher. So when you have a postmenopausal women, the general teaching is when the endometrium thickness is more than 5, you always do a sampling. In women who have a polyp and are symptomatic, when the polyp is more than a centimeter, you definitely need to remove it and make sure it doesn't have a malignancy. Even if she's not symptomatic, when the polyp is more than 18 millimeter, a polypectomy should be done and malignancy should be ruled out. These are according to the RCOG guidelines. When it comes to treatment options, you could either do a conservative approach or choose a surgical approach. In the surgical approach, hysteroscopy is the gold standard. Let's see who fits into the conservative approach. Asymptomatic premenopausal women with small polyps which are less than a centimeter, it is believed that these polyps can regress over 1 year. So these are the ones who fit into the conservative group. Again, the rate of regression is higher in women with sessile polyps compared to women who have a pedunculated polyp. That's the reason we say when you see a vascular stalk, it's always better to counsel the patient to have it removed. In women who are subjected to HRT and tamoxifen, you could discuss with them saying that they have high risk to develop a polyp, and maybe you could consider putting in an LNG or IUS, which will help to reduce the incidence of polyp. There's no role for expectant management in postmenopausal women with polyps. Similarly, in women who come to us for fertility and RPL. When we look at the surgical options in the management of polyps, long time tested people have been doing DNC, but that's not the procedure to be done because focal malignant lesions can be missed. There are some people who just put in the scope, identify where the polyp, and then go curate it or keep, removing it with all sorts of graspers and other things. That's something we shouldn't be practicing in today's era. It's time all of us learn how to do the scope, as what Lakshmi Madam was telling, and we must all get the art of doing a proper hysteroscopy. It is just the way we use CTG in our obstetric units and ultrasounds in obstetric unit. We must start using hysteroscopy in a gynae units. So in today's era, I think hysteroscopy is the gold standard and the procedure that we must be doing. Hysterectomy as an option for management of polyps is a big no and should not be practiced. So the gold standard hysteroscopy is actually a very easy procedure. It's only the level 2 of hysteroscopy by the ICOG classification, and as all gynecologists, we must acquire the skill. When it comes to hysteroscopic management, the various ways by which we could manage these polyps are just removed with graspers. You could resect it with scissors, or you could use current, either monopolar or bipolar, using a resectoscope. Office hysteroscopy is catching up in a big way now. Hysteroscopic modulators are again an addition into the armamentarium. So I'm just going to show you a few videos of how polyps could be tackled. In first, fertility patients. See, this is a patient who has come to us with a fertility issue. She's having a small fundal polyp. Rest of the endometrium is normal. It's been proven, and there are enough literature studies to say polypectomy per se increases the pregnancy rate, and in women with RPL, it definitely increases the take-home baby rate. You can do the polyp in these conditions with a micro scissors or a grasper, because in infertility patients, especially those who are waiting for the ET, I wouldn't advocate to use an energy source, because the amount of thermal damage that happens with the energy source is more compared to what you would get with using the scissors. A very simple procedure could be finished in a couple of minutes and you can come out. If you're not very comfortable using the scissors, another way is to use a grasper, which could be a simple grasper or a 3-pronged grasper like this. Go to the base, snap it, and get a good grip of it and walk your way out with the polyp. This is another technique of doing a polypectomy. The next thing is, when you have patients who are being worked up for DHL, there are occasions when you can find tiny ostial polyps like this. Even though chromoperturbation is positive and they have patent tubes, when you find polyps like this, which are acting like flap valves, it is always better to go resect them. And when you resect them, again, as stated already, do not use an energy source, because the amount of scarring that can happen would really lead to an osteal stenosis. So don't do that. In pedunculated polyps, always use a grasper or a scissor to resect it. Or if the polyp is sessile and it's very small, don't be in a haste to go pull it out. That is when more stenosis can happen and you can be really damaging it more. So the teaching is flap valve or mobile polyps need to be removed. Pedunculated ones, when it is sessile and very small, you really don't have to remove it. The angulation may be difficult. Angulate it in a way such that you get to the base. The next type of polyp in the fertility patient itself is one which is slightly bigger and occupying the cavity. When you have big polyps, the first thing that you need to judge is it okay enough to slip out of the internal os if you do an en bloc section? If you feel and you assess it's done, then you can go resect it. I am a person who uses more of scissors, but there are people who like to use monopolar needles or bipolar needles, which can be used through the same 5 French, instrument chamber, and using the same operative sheath. You can do not necessarily that you have to push it to use a resectoscope. Instead of cutting it open totally, you can just leave a small stem of it and then put in your grasper so that you don't have to keep hunting the polyp, which is just floating in the saline. When you have women who are not really desirous of, fertility and who sit with polyps, the next thing, as I already said, was always assess the size of the polyp. This is a postmenopausal lady. You can look at the atrophic endosperm all around and a small polyp sitting in the center. Here, again, you could use your monopolar needle or a bipolar needle, but as I said, I'm more a scissors person, so I'm just using the same scissors for this patient also. Go resect from the base, and once you have done it, you could either put a grasper. Another way of retrieving the specimen would be, once the resection is done, what you can do is you can push in as much fluid as possible, close the outlet, and then suddenly withdraw the scope. The polyp just comes out and falls. So that is one way of retrieving the specimen when you have a slightly bigger polyp which can come through the internal os. The next condition is when you have even more bigger polyps and the pedicle is really bigger for you, which you may feel you may not be able to do it with a scissor or a hook needle, then you start using your resectoscopes. Here, instead of doing an end block resection for the slightly bigger polyps, you need to slice them. When you're doing polyps on the lateral wall, you have to slice them parallel to the base. When you're doing on the anterior posterior walls, you have to slice them perpendicular to the base. Okay, this slicing technique has been promoted by Betoki, and that's something which we need to follow so that we get the size reduced so that it slips out of the internal os with ease. So resectoscope, if you're using a monopolar, glycine is a distension medium, and you need to keep account of the fluid deficit meticulously. If you're using a bipolar, you could push your margins a little more. Safety was also enhanced. The next scenario is where women come to us with multiple polyps. If you look at this patient, she has more than 7 polyps of varying sizes occupying the entire cavity. So in these cases, what we do is we go start resecting one by one, and the chips do obscure the way. So sometimes we need to pull off the scope and push it in again. But if you ask me if this lady is going to be a candidate for recurrence, yes, she's highly prone for recurrence. So what do we do to prevent recurrence in this lady? Either you come out with a specimen and make sure there's no atypia and malignancy, and then put in a Mirena, or if by visual inspection, if you don't suspect a malignancy, you could still go ahead and do a TCRE, which is as good as your Mirena, or the same way which has been time tested, being done by many endoscopic and hysteroscopic surgeons. You remove the entire basal endometrium until the level where the myometrium gets exposed. So this creates an artificial Asherman's, and many of my patients get amenorrheic or even hypomenorrheic sometimes, and the incidence and recurrence risk of polyps is really less in this patient. But you have to go resect the entire basal endometrium deep down to a level where the myometrium gets exposed. And that's what is being shown in this video. You have to really denude the basal endometrium, and this has to be done all around. You should not allow a place even near the ostia. It should not be left because the endometrium can quickly regrow. So when you go to the ostia, which is the thinnest area, if you're scared to use the resectoscope, you can just use your roller ball to cauterize that itch. Then we come to a condition where you have FIGO type 0 myomas, which do present like uterine myomas. But the differentiation is that an ultrasound, they are isoechoic with a myometrium. And when you start resecting them, they have a gritty feel. It is like a gravel compared to what you would have in a polyp, which would be like cutting a butter. So here I'm using a resectoscope because it's not going to be that easy to pull out if you cut it en bloc. You need to do the slicing technique, same principles like what you would do any polypectomy. You have to make small chips which can be removed. Always work towards the scope so that the incidence and chances of inadvertent injury to the fundus or other structures are not there. So when you start resecting, what happens is chips start, filling up the cavity and they start obscuring your vision. So that is time for you to remove the scope, remove the chips and put them again. So you need to be very careful in doing this because every time you do this, the vision gets hampered. The fluid deficit is more because you need more fluid to wash it out. So you have to really be watchful about it or push the chips to the fundus and then work. When you have myomas of opposing surfaces and it's a fertility patient, if you're going to tackle them, you have to think about adhesion prevention or sometimes even a second sitting or calling for a relook hysteroscope to tackle the adhesions should be kept in mind, especially for fibroid polyps. These are tiny cervical polyps which project through the os. They give you a happy feeling that you can just hold it with a sponge holder and can snare it. But we have to be very sure that the base where it extends. Sometimes it extends from the lower uterine segment or even higher. So if you just snare it from down, what happens is the recurrence risk is higher. This video is just shown because after snaring, you can see there is a redundant portion which needs to be excised. So when you have a cervical polyp and you're tempted to remove it, unless and until you are sure the stalk is within the cervical canal, always put in your hysteroscope, go resect the base so that the risk of recurrence is definitely brought down. As we were all discussing, hysteroscopy is far moving from, at least for diagnostic procedures and small procedures like foreign body removal or taking biopsies or small polypectomies, is moving out from the office to the, from the OT to the office. We are like doing our office hysteroscopes and properly counsel patients. You have to tell them what it is and how they would feel, where they need to tell us to stop. And if you have a 2.9 or a 1.9 mm hysteroscope, just take off the continuous flow irrigation, push only the inner chamber and connect to a fluid and start entering by using the vaginoscopic technique. If you don't touch the cervix and you don't put a tenaculum in the cervix, it's hardly pain. There's hardly any pain. And if you can see, I would not be touching the cervical lips in any way. Walk your way inside, identify the polyp, and using a grasper without giving more traction on the endometrium, gently push it inside, and then you will be able to retrieve it. The maximum we do is to do a cervical priming with Cytotec, or in some patients, maybe a paracervical block is required. We hardly even use a TIVA in any of these patients, and we get them also a part of it. We ask them to keep saying the monitor. They're also enthralled. Imagine they just come 1 hour's time, they get the procedure done, and they go home the same day. This is another case which was done using the Endo-C Advance. It was a postmenopausal lady reported as multiple polyps. Endo-C Advance is a handheld portable device. So when we went in, what we saw was this pathognomonic picture of ulcerations, necrotic area, abnormal vascularity, and irregularity. So we knew we were dealing with not just a normal endometrium, it was more suspicious of a malignancy. So a polypectomy sort of condition was not done here. We just had to biopsy and come out. It was proven, and then the patient was taken up for radical hysterectomy. All these are done in the comfort of your office. So that is again cutting on the cost, and the patient gets the results and the treatment done immediately. So that way, it's again an added advantage. New kid on the block is a hysteroscopic morcellator, and this is a case of a large polyp which is being tackled with hysteroscopic morcellation. Here, we use mechanical energy, no electrical energy sources used. So you have different speeds and different sort of blades. These are all shavers, which you need to put it on the polyp. I'm just trying to actually bisect it because I'm not really used to it. I'm just 3 cases old with this. So you need to put it onto the wire, and then it starts to literally eat it up, is what the company guys say. It tends to eat it up. The pieces are not lodged in the cavity. They get sucked into the suction bottle, from where you will have to retrieve it and use it. It is definitely much easier to learn. It's got a shorter learning curve, is what they say, but the vision is not obscure, and you can do bigger polyps, you can do multiple myomas, all the comfort of using saline as a dissension medium, no energy source. That way the risk of injury is also less. But the biggest disadvantage is the cost, which is little pricey, I think, for Indian scenarios and small setups. So these are a few videos of how various types of polyps could be managed. When we talk of recurrence, I think LNG-IUS in properly selected cases has a role. Gynogeston and tibolone are there in literature, but I have no personal experience with them. Hysterectomy as a modality to prevent recurrence or management of recurrence is a big no. Coming to the question posted to me, when you have a case of endometrial polyp, first thing we need to do is classify them as asymptomatic or symptomatic. If she is symptomatic, irrespective of whether she's premenopausal or postmenopausal, polypectomy is the procedure that needs to be done. Then we come to the segment of asymptomatic patients. Now you classify them as premenopausal and postmenopausal. Again, a postmenopausal lady who's asymptomatic also requires a polypectomy. Now we have the premenopausal group. Here, we need to assess the size. If it is more than 1 centimeter, we fall to the group of resection. A polyp which is less than 1 centimeter in a premenopausal asymptomatic patient is the one who can be kept for expectant management. Over the period of time, if she develops symptoms, again, she falls into the category where the polyps need to be removed, or if the polyp grows and becomes more than centimeters, she has to be taken up for removal. So these small segment of patients can definitely go for the wait and watch policy. These are the guidelines given by ICOG, and this is in a nutshell to the question given to me. Once again, I thank you for the opportunity.
Thank you, Vanita. It was indeed a comprehensive presentation with nice videos. And the best part I thought was, you made those videos look doable. So whosoever is watching it should feel that he or she should be able to do it. So thank you very much for the videos and the presentation. I think we'll take the discussion at the end. We have a special, am I right, Palani?
Yeah, we will.
Yes, we
In
have
the
a
hysteroscopy session, we will have questions for all the 3 speakers. Yeah.
Right. Over to you, Sushila.
No. If it is the questions that we are looking at, we can have it at the end of the session. Thank you for having me over here to chair the session. And it was really wonderful to listen to Dr. Vanita. And many very practical, very doable, and small tips that can go a long way, especially for those who start working on hysteroscopy. Thank you.
Dr. Sushila, you can introduce the next speaker.
Yeah.
Yeah.
Who is speaking next, Palani? Yeah.
Dr. Krishna Kumar.
Yeah.
Yeah, it's my pleasure to introduce Dr. Krishna Kumar, who's the consultant at JK Women's Hospital, Fortis Hospital, and who has been the immediate past president of Indian Association of Gynaecological Endoscopists. He is an ISHRAE certified reproductive endoscopic surgeon, and the center is recognized for ICOG fellowship, 6 months ART and endoscopic surgery. He's also the recipient of the National IME Award 2019-20, eminent medical distinguished achievement of highest order. I think we have a very distinguished speaker here. Over to you, Dr. Krishna Kumar.
Yeah. Good evening.
Welcome, sir. Welcome to ICOG.
Thank you. Good evening, and thank you for inviting me to this masterclass. I hope you can hear me well.
Yes.
Yeah, so let me share the screen. And of course, I just got the message that I have to, Can you enable me to share the screen?
Yes, sir, you can share the screen. Yes,
It is written
sir.
host disabled screen sharing.
No.
So now you can share. Yes, ma'am, I've done.
Yeah, please share. You make all the speakers co-host, Komal.
Yes, ma'am.
You are muted, sir. Krishna Kumar, sir. You have to unmute. Komal, co-host बना दो सब speakers को. हाँ.
Ma'am, कर दिया है. Done, ma'am.
हाँ. We can see your slides. Yes.
Slides are moving, sir.
Yeah, they are moving.
No, there is some problem. I'm unable to unmute myself.
No, but we can hear you now.
Can you hear now?
Yes.
Yes,
We
very
can hear
clear.
you, sir. Please go ahead.
Yes.
Yeah, fine. Thank you for the invitation. So just a little bit early, I am here. I'm going to be talking on managing the septate uterus. And of course, the septum presents in different configuration from partial to complete and even to vaginal, and there are other variations of septum. But in general, an indentation greater than 50% of the myometrial wall thickness or greater than 1 centimeter depth as per the ASRM means here we have to differentiate between the arcuate and a true septum, because arcuate uterus, now all said and done today, we don't believe it needs correction. Now, amongst all the congenital uterine anomalies, luckily for us, septate uterus is the commonest one, as you can see in this, almost 15%, because septate uterus is something very, very easy to treat. And with the advent of hysteroscopy, it has become like a cakewalk, or absolutely very simple. But one must remember that one corrects septum only in patients who have obstetric implications, and septate uterus are known to cause. So anybody desiring family, pregnancy, only then you are going to take care of the septum. Otherwise, septum incidentally found in any other instance, one should not bother to really correct it or go after it. Well, I wouldn't go into the various classification. It falls into the U2 mostly, and occasionally some of the U3 as per the ESHRE-ESG classification, but the recent ASRM classification gives a very broad view of the congenital uterine anomalies, and it also takes care of the various septum configuration which we have, right from partial, arcuate, the even Robert's uterus, the vaginal septum. But today, with the availability of good imaging, once you are suspecting septum, a good transvaginal 2D, and of course preferably 3D, will almost all the instances tell you whether you are dealing with a didelphys uterus or a septate uterus with the thickness of the fundus there. And I wouldn't go into the various ways of really diagnosing by the angle and other things in this webinar today, because I'm going to primarily talk on management rather than diagnosis. But the one must go through this ASRM article for really understanding all those angles of 40 degrees, 90 degrees, as to really differentiate by the imaging itself how to differentiate from an arcuate, a septate, or a didelphys uterus. Now, what is proven beyond doubt, that amongst all the uterine anomalies, we know that adverse reproductive outcome is known. All the uterine anomalies have a higher first trimester or second trimester miscarriages, preterm labor, and of course malpresentation at birth. But what is obviously been proven also is patients with septate uterus have a decreased conception rate. This has been published in a very beautiful article by Shen et al. Way back in 2011. So today there is no doubt that if you see septum in any woman who has even a single pregnancy loss, if it's beyond 1 centimeter, I would go ahead and correct it. Well, the evidence is beyond doubt. Again, various papers very easily say that surgery on a uterine septum improves the chances of pregnancy, improves the chances of miscarriage. Improvement definitely favors surgical treatment and even preterm delivery. So the papers are undoubtedly saying that septum should be taken care. Now, this study by Pryor et al. In 2018, where he took patients who were for reproduction, that is for ART, almost 2,400 women, and he did embryo transfer in women who had normal arcuate, septate, or other defects congenitally possible. And what he found was very, very fine in his paper, where you can see that both normal and arcuate, the clinical pregnancy rates are almost similar, and the live birth rates are almost similar. So stating that arcuate uterus doesn't come even in the problem implantation. Well, as far as the clinical pregnancy rate goes with the other anomalies, you can see in the second column very clearly, the clinical pregnancy rate is decreased in septate and subseptate uterus, and even the live birth rate is hardly 22%. So, whereas unicornuate, bicornuate doesn't seem to really impair implantation. So, septate uterus, you are justified if you are going to do an ART. If you see a septum, you are justified in correcting it before you can transfer the embryo. So, this is a very, very nice paper published in 2018. Well, it is beyond proven that there is a very strong evidence that hysteroscopic surgery for intrauterine pathologies improves clinical pregnancy rate. The evidence is very high, level A, and today it is definite that we need to correct all septum or all intrauterine pathology by hysteroscopic method. And with the improvement in all the instrumentation today, we have the various ways of doing with the hysteroscope. Most of the septum today we are able to do with that simple 5 millimeter or a 4 millimeter sheet and a 2 millimeter scissors. that is with just the operative sheet and no need of the resectoscope. You can have the use of the needles which are available, both bipolar and monopolar electrodes. Where it is not possible, you need to go for resectoscope. You can go, but now today we are blessed to have even smaller diameter resectoscope, right from 5.5 millimeter. And laser is something, of course, I don't have any experience, but no technique has been demonstrated superior to the others. But today, any intrauterine treatment, we believe if you are doing for a reproductive reason, we should avoid using energy, and we should try and see whether you can finish up with the Caesars, or just now was mentioned that morcellators have gained importance. Now, this is a subseptate uterus. What I'm trying to show is the moving Caesars should be pointed towards the ostia. So where to cut the septum is always a question for a beginner. You need to be in the midline, and you will be in the midline if the ostia is under vision. So your moving blade should be absolutely parallel to the ostia, and keep it exactly in the center and start from the apex of the septum. Well, identification of the septum is difficult in subseptate uterus. You have to remember that the ostia is always deep. There is a projection of almost 1 centimeter in the mid cavity. And here, this is, you can see a 1 centimeter septum cut. Where to stop? I will be coming in the next slides. Now, this is a complete septum starting right from internal os. Again, I would start off with the Caesars, and you can see the HSG finding, which is there very clearly. You can see the septum most of the time will be fibrous. Here, you can very classically see that as you go to the fundus in the HSG, the septum becomes broad, where it will be more of muscular. So most of the septum don't bleed. 80% of the time, you will get away with just simply cutting it with scissors. Again, the same principle, locate the two ostia, remain in the midline, start in the apex, which is the thinnest part, and it will be fibrous initially. You need to have good scissors, and that's all. You don't need any energy. You don't have to really bother about those occasional oozers which may just come in your view. If you have a good pressure, those bleeders stop. Of course, I wouldn't go into the detail of maintaining what pressure and flow rate, but we generally do not go above 150 millimeter of mercury for the uterine distension media pressure. And here you can see as we go up, we'll be seeing that the septum is becoming a little more broad. But you need to, change your angle from one ostia to the ostia. Don't keep going on one direction only. You may falsely enter the fundus at one side. So you need to, change your scissors position from the right to the left. You should see the other ostia intermittently so that you know where to cut and how much more to cut. As you can see that the ostial cup is so deep here. So you need to definitely cut much more. You must remember that the ostia is just a little above the fundus. It's about 4 millimeter or so, 5 millimeter maximum. The ostia is never below the fundus. Ostia is always above the fundus. You don't create an umbrella, but this is how the fundus is. These are the two ostial positions. So that's where you ideally stop using the scissors. Now, what to do if you see a septum in a routine diagnostic scopy and it has not been picked up earlier? I would recommend that if you're doing with the scissors, go ahead and cut it. Don't wait for the obstetric problems like preterm birth or abortion. Doing with a scissor is considered absolutely harmless. And as you can see now, when we are going above, we are finding that the septum is becoming a little more broader. But most of the septum will not really bleed. Where you find that there is a lot of vascularity and there is more bleeding, you may change over to the cautery or take the electrode and just cut the rest. But as I said, today we have learned the trick, and almost 80% of all our septum we are able to complete. Now you can see at this part, the septum is becoming more broader. It spreads further as you go closer to the fundus, where it is going to be really more time to take to cut. You may find that the fibers are a little more muscular at this point. But the end point, as I said, stop it where you are going to be just below the ostia. And usually, most of the time, septum doesn't require 2 sittings. You can cut all the septum in one single sitting because fluid absorption is never a problem. These are some of the other modalities where you can see the same operative sheet. You can see the Versa electrode, which we had in the past. And today we have these monopolar and bipolar electrodes, which can be also 2 millimeter passed through the same 5 French sheet. And you can see that you can use the cautery, but these needles are very, very flimsy. You need to take care that they don't break. And of course, because of the flimsiness of the electrode, you have to have a little bit training, but then it becomes as simple as a painting with a brush. All you need to do is from one side to the other with the same principle, keeping the ostia always under vision. Well, today we don't use much of the electrode because, as I said, we are able to do with the scissors, and we are trying to avoid energy at all costs. Well, complete septum, something which you will see many a time. So this is the case of a complete septum where you can see that the fundus is also doesn't look very broad. So this is not a bicornuate uterus. This is a single septate uterus. So this patient had many patients with vaginal septum. Here you can see on the left side, we are cutting the vaginal part of the septum also with the same resectoscopic electrode. Either, of course, you can cut them with the scissors, that doesn't matter. But on the right side, you see how this cavity looks. So one side, you are seeing one horn of the uterus. You come out, you can see only the tubal ostia right at your 12 o'clock position. And then the other side you enter to identify that the two cavities. The cervical part of the septum is sometimes tricky to cut. You may not be able to cut it with just your regular scissors. So this resectoscope, how to use it, I'll just show you. So this is the left horn of the cavity, which you are seeing here. And this is one horn and the other horn. So here today, with the availability of the smaller resectoscope, because as you can see, this slip of cervix in an anomalous uterus is always very difficult to catch. So today, with the availability of the smaller resectoscope, we are able to pass it without any need for dilatation or holding the cervix. So that's where I would recommend that you should have all gamut of instruments if you want to really go to it. This is a 6 millimeter bipolar resectoscope where you can see we are entering without holding the cervix, without holding the without dilating. Now, going on one side, here I am on the left side of the cavity. I know that the right side cavity is there because that is the septum. Just above the cervix or the internal os, which will be the thinnest part, you need to just perforate with your needle. You're not going to enter the uterine artery. You know that the right side horn is there. You just perforate, and then it is like tackling a regular complete septum right from the internal os. So here, of course, I'm showing you the use of the bipolar resectoscope needle, or called as the Collins knife. With the same, the Collins knife tip should be pointing towards the ostia at all times. You can go from one side of the ostia to the other ostia, but pass the current very, very judiciously. Don't try to use the current more than 4 or 5 seconds at one go. It's ideally better that you just do little, and then the rest of the cervical septum, you can see I'm just cutting it with the needle here, passing from above below. So this is showing you how to cut a complete septum. Well, Robert's uterus is one variation of septum where you can't see the other side of the cavity. The opening between the two cavities is very narrow. The septum is usually adherent to one part of the cervix, and there may be a small opening from where the menstrual blood is coming. So these patients don't land up in hematometra, but sonographically you can see two cavities, but you will be seeing only one cavity. So you need to identify that, and exactly the same way as we did just above the internal os. Identify the mucosal fold and thus use the same Collins knife. Here you're seeing this 26 French or the 9 millimeter bipolar resectoscope being used. You just perforate, and as you can see, this is a little more tricky. The septum is a little more broad, so you're taking much more time than we saw in the previous. But if you're sure that the other side cavity is definitely existing, you're not going to bother. And once you see the other cavity is already seen, I wouldn't play the video further because this is already you have seen. The same way, keep the Collins knife parallel to the ostia, and keep cutting, and end point is the same identification. As you can see, we have cut, and the rest of the cervical septum will be tackled now. So this is the Robert's uterus. So this is actually Ovira syndrome, where the septum is in the vagina, a transverse vaginal septum. These patients will present much earlier with severe abdominal pain, and this is the presence of the transverse vaginal septum is not allowing the menstrual flow. So these patients will present. You can see the bulge here in the vagina, and you can use the same resectoscope to just keep opening in that part of the septum which is in the vagina, obstructing the menstrual flow. You can see the chocolate colored fluid coming, and then the patient is definitely relieved. The procedure is very simple, and today with the availability of the 6 millimeter, even the hymen can be preserved in these patients who desire preservation of the hymen. So this is how you further cut the septum. So this is a Ovira syndrome, which is very rare, does come occasionally. Now, there was a controversy raised by the Italian group whether septum is like a fibrous tissue. They said incision is not enough. They need to resect the whole of fibrous tissue. What their theory was, as you can see, there is a myoma-like fibrous tissue in the center here, and that is what they said, that you need to, excise it completely. So what their theory was, that you need to not only laterally resect it off, and the midline spur, which you can see here, should also be cut. But using a resectoscope inside a uterus, who is for reproduction, looks dangerous, and it has not many takers have taken this. So this theory is still not been accepted by all. But this was just, I was just trying to highlight this, because at many conferences people do tell us that the rest of the fibrous tissue has to be resected, but you never see that projection of the septum into the cavity of the uterus once you incise. Usually it gets up above, and the endometrium is always much below. So there is no need to resect the septum. Postoperatively, one must know that we routinely give estrogen 3 times a day at least for about 20 days, followed by medroxyprogesterone. And septum heals the slowest because it has a lot of fibrous tissue, and you have to wait for 3 months before the patient is for infertility treatment. Very rarely you find adhesions postoperatively. The incidence reported is around 7% in the JMIG 2018. Very broad vascular septum. We occasionally keep a pediatric Foley catheter for 5 to 7 days and monitor them after 2 or 3 months under transvaginal for the endometrial thickness development. And very rarely we have to do a second sitting. Almost none of the cases require. So hysteroscopic septoplasty is more than a ray of hope for a condition which was otherwise non-amenable, because in my earlier days as student, we used to read those Strassmann cystoplasty and how to cut the muscle to uterus hole to cut the septum. I could never understand. Hysteroscopy has made it very simple. Definitely, it's given a great ray of hope for all those patients who had multiple pregnancy losses. Thank you for a patient hearing. I would recommend that you should read this wonderful article, Surgical Management of Congenital Uterine Anomalies, written by Theodoras and Theodoradis. Thank you for a patient hearing.
Big boss.
Thank you, Dr. Krishna Kumar, sir, for a fantastic treat for the eyes. I think you have one of the largest case series of hysteroscopic surgeries probably all over India, maybe even the world. It's really wonderful to watch all your videos and to learn from you. Thank you so much. I was once upon a time privileged to work with sir, so I have seen him firsthand.
With us for 17 years, so he definitely knows. I'm unable to stop share. Of course, I hope I could convey whatever I wanted to convey.
Yes,
sir. Thank you so much.
How to talk after KK Kumar?
You made me talk to you, Raja. You are a busy person. We're lucky that Atul is there for the lecture. Otherwise, he's never been possible for him to come.
No, Atul is very much here with me for ICOG things now.
Thank you.
So I have the privilege of introducing the next speaker, Dr. Atul Ganatra, sir. Sir is a managing committee member of the Mumbai Society. He's also an office bearer of IAG, vice president of FOGSI very recently, and a past chairperson for the FOGSI MTP committee. Thank you very much, sir, for being with us today. And sir is here to talk about, yes, sir.
He is the secretary of IAG now.
Yes, I said he's an office bearer of IAG.
Playing safe.
And to
Welcome, Atul. Welcome. Keep coming to
you.
ICOG platforms. We need good teachers.
Thank you so much. And it's
And
an
another
honor.
important topic, whether lateral metroplasty is something which is really required. What is the evidence for it today? And I think sir is one of the best people to guide us regarding. Over to you, sir.
So thank you very much. It's an honor to come on the academic wing of FOGSI. I hope you can see my slides.
Yes, we can see.
If you could go full screen, sir.
It's an absolute honor
Thank
to
you.
come on the academic wing of FOGSI with such lovely friends holding the torch and doing a great job. I was again honored by becoming an examiner for endoscopy recently at one of the ICOG exams. Well, if you do what you've always done, you will get on with what you've always got. I think this is what an absolutely true story about endoscopy and more so hysteroscopy. We have to progress. Being the secretary of IAG, take 1 minute to say that if we have 4,000 members who do laparoscopy, I think we have hardly about 500 who do hysteroscopy. And I think it is a moral responsibility of the office bearers and the managing committee to see that we train more and more people who do hysteroscopy, and who better than Krishna Kumar sir to hold not only the cadaveric course, but the hysteroscopy course as well. Lateral mastoplasty, the evidence. I am standing here with my head high because of two people. Dr. Noza Shariar, who was my mentor, who taught me and handheld me into hysteroscopy. And of course, Dr. Krishna Kumar, who's probably one of the biggest people in hysteroscopy in the country and the world. The female genital malformations are defined as a deviation from normal anatomy due to impaired development of the Mullerian or the paramesomacry ducts. The incidence in the general population is 0.2 to 0.4%. In the infertile patients, it is 4 to 3%. And often, uterine malformations are associated with recurrent miscarriage. The T-shaped uterus, I'm going to limit myself to the T-shaped uterus. You can see this wonderful article of 2021. The T-shaped uterus is a congenital uterine malformation. We will be referring it to it as CUM, only recently defined by X-ray and ESG as class U1A. The uterus is characterized by narrow uterine cavity due to thickened lateral walls with a correlation to third corpus and 1/3 cervix. Although the significance of this dysmorphic malformation on the reproductive performance has been questioned, recent studies, though small, show significant improvement of live birth rate after surgical correction in these patients, especially underlying failed IVF or recurrent miscarriage. I don't think we would want to venture into these situations otherwise. Dr. Krishna Kumar just mentioned this ESG classification to you, and we fall into this class 1A category when it comes to the T-shaped uterus. And this particular 3D ultrasound picture classically tells you when to operate and when not to operate. I'll read this, and I want the students to by heart this if possible. The classification of uterine anomalies. Class 2, indentation of more than 50% or uterine wall thickness, extreme contour less than 50%. In the class 3, it is more than 50%. We'll talk about it further in our subsequent slides. The prevalence of the T-shaped uterus among infertile women based on the X-ray ESG classification, the CUM group, and the criteria. These people thought that it is worth doing it, whereas there are certain articles that say that the incidence has to prove that this surgery has any benefit at all. This is another article that is supporting the surgical treatment of a T-shaped uterus. But the general consensus, the prevalence of the T-shaped uterine infertile women is low, which corresponds to previous reports with poor reproductive history. So the moral of the story of my talk is only if there is a poor reproductive history, like a recurrent miscarriage or failed IVF, that we should do a metroplasty for T-shaped uterus. T-shaped uterus originally thought to be the effect of diethyl stilbestrol on reproductive function. And this 2015 article, comparison of the ESG and the RSM classification of the Mullerian anomalies in everyday practice, said that no matter how small the study is, if I see a T-shaped uterus in a patient, I'm going to do IVF. Am I going to wait for her to implant or to fail implantation and then metroplasty, or I'm going to do it when I see it? I think today, if I've proven a T-shaped uterus by which I'm going to talk about, I think I would definitely go ahead and do metroplasty if I have omitted all other factors of recurrent implantation failure. An abnormality with constriction rings around the proximal uterine segment, narrow uterine cavity, thick lateral wall was described by the AFS as a type 7 DES type of anomaly. Almost 2/3 of women exposed to DES developed uterine abnormality, though nobody now takes DES. Detector or HSG, the most common being T-shaped uterus. Women exposed to DES with abnormal findings on HSG had an increased risk of ectopic pregnancy, also a threatened miscarriage and a preterm delivery. So how do you define T-shaped uterus? By this ESG-ESHRE criteria. This is a 2021 article. Recently, the congenital uterine malformation group of experts identified the best measurements that had good diagnostic accuracy and fair to moderate inter-observer reliability and agreement. The best cutoff values, and an angle of more than 130, a lateral indentation depth of more than 7 millimeters, and a T angle of less than 40 degrees. T-shaped uterus, indication for surgery, failed IVF, recurrent miscarriage, thin endometrium, preterm delivery. I would add one more point here. If I see a T-shaped uterus in a patient, I'm going to do IVF, and I have fallen into these criteria as mentioned, I think I would explain that to the patient and go ahead and do a metroplasty. This is a patient who was assuming that there is a T-shaped uterus with hysteroscopy. There is some indentation, but I'm not convinced this is T-shaped uterus. HSG, as you can see. Weeks pregnant. This is how a normal unicornate uterus looks like on HSG. Look at this unicornate uterus, almost like a slender pipe. Here, we went ahead and did the metroplasty just by using scissors, with the hope that we broaden the cavity a little bit. I don't think you can get a cavity like a normal uterine cavity Here, I would completely agree with Dr. Krishna Kumar. I'm going to use scissors, just try and see that I can create a little better lateral wall on either side so that the endometrium at least reaches between 6 and 7 millimeters. You need to be very, very slow because you know, as you see on the HSG there, that the cavity is very thin. Here, this is a normal cavity and this is my target. My target is to achieve a cavity. Fortunately, we've done about 6 or 7 IVFs on patients with universes. And fortunately, all of them have conceived in the last 3 years. And the most important factor, remember that while I'm cutting my scissors, there is absolutely no bleeding, which means this is fibrosis, this is unhealthy. The idea is to stop the minute you see bleeding. In they would give the pill so that the endometrium becomes thin prior to doing myomectomy or a septum, but I don't think in India we follow that principle. The idea is to just create adequate cavity, just good enough so that the patient does conceive. This patient had come to us from Uttar Pradesh. Unfortunately, she's 28-week pregnant. As of now, we've not done a cervical stitch on her, and we are hoping that she carries the pregnancy at least till about 34 weeks. A little bit of fundal metroplasty. The cavity does look a little better. And obviously, you would give the patient estrogen, progesterone, and maybe even put in a Foley's catheter for a week. Unfortunately, ethanyl estradiol is not available, and that's why we need to give them fairly high doses of estradiol valerate, or maybe sometimes even the gel. I'm a little more aggressive and I use the estrogen gel now, because sometimes patients on Proguanova do have a little bit of intermenstrual bleeding. The next case, again, patient with 2 failed IVF attempts came to us for an opinion. We had a 3D picture of her. Unfortunately, I couldn't find it. We did a metroplasty again because we thought on 3D that the lateral walls were convergent. Of course, we had ruled out other factors of recurrent implantation failure. We do our ANA and lupus titers in our patients sometimes when we have a failed attempt. We went ahead and used the scissors. I use a combination of scissors and the resectoscope. Towards the end, finishing edge, I sometimes use the resectoscope as well. And this patient, after 2 failed IVF attempts, conceived spontaneously. I think we were very lucky. And I think we have to be honest to our patients and say that I'm doing it because I don't know what else is wrong. Everything else seems to be all right. And we don't know why you're not conceiving. This patient has fortunately delivered already. And like Dr. Krishnakumar said, that the ostium is about a couple of millimeters above the fundus. So there is, if you have a good optics, a good camera, there is absolutely no reason to worry, and you would probably get a good effect just with scissors. We, towards the end, do use a little bit of a resectoscope just to kind of get a fine end result. There you can see I'm using the resectoscope towards the end just to put that finishing touch. Because beyond the point, my scissor, I'm going a little blind, but with the bipolar resectoscope, I'm completely under control. And obviously, it is always better. The moral of operative metroplasty is to undercut than to cut more. Again, a patient previous abortions. This is the HSG, the 3 brought to us. We ruled out everything. And when we ruled out all factors, we did subject her to a metroplasty. And this patient again has an ongoing pregnancy right now. So the principle is very simple. Scissors, a stable hand at the camera, and if you are not comfortable with the scissors, you could use a resectoscope. The problem with the scissors is good quality scissors are expensive and break very easily. There have been times when I have been trading at another center and they have only 1 pair of scissors. If the scissors break, you have no other option but use the resectoscope. So you should be comfortable using the resectoscope. The only disadvantage is you have the 22 French, then you have to probably dilate the cervix a little more. So this is what we need to remember at the end of my talk. 3D ultrasound diagnosis of T-shaped uterus. According to this guy, the uterus showed both lateral indentation, depth of more than 7, bilateral T angle of less than 140. You can see here a bilateral T angle of less than 40 and a lateral indentation of less than 130 degrees. I'm going to show you these slides on a single basis. Here you can see the lateral indentation, which is more than 7 millimeters. The angle of less than 130 and a bilateral T angle of less than 40. I think these are 3 parameters that your radiologist who does 3D ultrasound for you should give it to you, just as you can see on this picture, and you should be able to kind of subject a lateral metroplasty if you've ruled out all other factors. This is a pre-op picture. This is the post-op picture, as you can see. This is the target of the metroplasty. Now, this is something new we learned, and if Dr. Krishna Kumar is there, he will guide us as to excision of the lateral wall, because they say just incising is not enough, and I think Dr. Krishna Kumar didn't mention it. Here you can see small resectoscope. Instead of incising it, you just go ahead and resect it on both sides, because they feel it is fibrous tissue and it must come out, and this fibrous tissue is going to hamper implantation. And if you have these small myomas, you can excise these myomas as well. This is not my video. I took it from the net, from the ASRM group. And I think this is something that is worth trying if you have a smaller resectoscope. And I think maybe we'll take 1 or 2 questions or comments from Dr. Krishna Kumar on this. So basically, the moral of the story, hysteroscopic outpatient metroplasty can be done. Conclusion, the metroplasty seems to be an effective, productive outcome. Another multicentric trial published in 2021, 2504 records, 20 studies, the prevalence and etiology on with respect to reproductive outcome of T-shaped uterus remains unclear. Expected management should be considered the most appropriate choice for everyday practice until RCTs show benefit. This is from 2020 International Society of Ultrasound and OBGYN. So unless you've eliminated all other causes, this study says you must not do a metroplasty, but we've definitely seen benefit. This is our 39 cases we've done in the last 2 years. Since 2019, we have a 41% pregnancy rate, and I think that's at par with IVF. Some were lost for follow-up, but I think if judiciously mapped ultrasounds are done, I think a metroplasty for a T-shaped uterus is definitely justified. To conclude, in the last 3 years, uncontrolled observational studies have been published demonstrating hysteroscopic metroplasty in infertile patients with a T-shaped uterus may enhance the reproductive outcome. So this is basically by process of elimination if you've ruled out all other causes. However, to date, there is lack of controlled observational or RCTs evaluating the reproductive outcome after a hysteroscopic surgical treatment compared to expected management, and the uncertainty should be discussed with women with subfertility and a T-shaped uterus. So we have to be honest with your patient and say, I'm not sure if it's going to work, but I think it's worth giving it a try because we've ruled out almost everything. Follow the process of make a habit to do 2 things, friends. Either you help or at least do no harm. Thank you very much.
Thank you, Dr. Atul Ganatra, sir, for taking us through a wonderful journey on lateral metroplasty. In the past, the procedure has been abused quite a lot, but I think you put the right evidence-based perspective on it and how it should be used in today's world. Thank you so much again, Dr. Lakshmi Shrikande, Dr. Parag Biniwale, and Dr. Palaniappan, sir, for having me here.
Pratik,
There are a few questions actually for.
Yeah, please.
Yeah, I think Palani will conduct that, I think.
Yeah, Palani, there are
Yeah,
few
sure, I'm ready with it.
Yeah.
The first question is from, there are a couple of questions. One is from Sushila Rani. She's asked, in an nulliparous woman, if you incidentally find a small septum, would you resect it? Dr. Krishna Kumar, sir.
Is KK there?
Yeah, I'm there. Sorry, I didn't hear the question.
If there is an incidental finding of a septum in a nulliparous woman, would you still go and do a resection of the septum?
No, if you are doing any procedure for fertility or infertility, then I would go ahead and do. Small septum means anything above 1 centimeter. You are justified in doing it if you're using scissors. You are not justified if you're going to use an electrode. I would go ahead and cut off the septum with the scissors.
If she's coming for a fertility enhancing procedure?
Not, yeah, she's come for a primary infertility and only positive finding you're seeing is a septum. I would go ahead and cut, because definitely implantation has been shown in so many studies I showed that conception rate is still less in patient with a septate uterus, and using a 2 mm scissors is not going to really harm our uterus or damage the uterus. So definitely you're justified in doing, and as just Dr. Atul said, you don't wait for an abortion to occur. If you just find incidentally on the sonography and the patient has still not even had 1 year of trial, I wouldn't advise or I wouldn't post her for a septoplasty.
Thank you, sir. The next question also comes to you. It's from Dr. Yukti Bharatwaj. Do patients of complete septal resection require a cervical encerclage after that, or what is the incidence of preterm labor in such a patient who's
Right. Now, of course, Dr. Tambe also will agree. In majority of patients where we have found that they all seem to be having incompetency of some extent. So if it's a complete septate uterus, I would definitely go ahead and do a prophylactic cerclage, whatever that 14-week sonography may show, because if it's a partial septum, I may not want to do a straightening of the os. But if it's a complete septum and we have incised, or even if we have not incised the cervical part, I think doing a straightening of the os is very, very essential, because they all have some anomaly even at that cervical. And there have been various reports. If I had time, I would have shown that definitely the cervical muscle is also impaired in these patients. Connective tissue are impaired in these patients.
The next question, I'm sure Dr. Atul would be able to take it. If you do a lateral metroplasty, what do you think is the risk of cervical incompetence subsequent to that?
I don't think there is any risk of cervical incompetence
With the metroplasty.
Even for the intrauterine septum, like Dr. Krishna Kumar said, if I have a septum which is about 1.5 centimeters, I will, at the time of my hysteroscopy itself, tell my patient that there is a small chance that 50% of patients will develop cervical incompetence. Just like in twins, I don't put a prophylactic stitch on all twins, but I do aggressively look at their cervixes every 2 weeks, and the smallest of indication when the cervix becomes less than 3 centimeters, we would put a stitch. Similarly, in a septum, metroplasty, I don't think there is any incidence.
And should
What you have to take care is you don't cut at the level of the internal os. You remain above the level of internal os. When you
always stop in time. If you don't stop in time, you are the one responsible for the poor obstetric outcome later. So you have to take that responsibility and ensure that your hands are very controlled while doing the.
In fact, when you do a lateral metroplasty, you first mark an area above the internal os with your resectoscope, and you don't go beyond that. If you don't do that, you'll probably overcut sometimes.
The last question here is, should we routinely do a hysteroscopy in a IVF failure patients, or when the 3D scan is normal?
That's very controversial. It's not required. Most of the studies have shown that you don't need to do after one IVF failure if the 3D is normal, unless you are suspecting or some element of previous history of infection, PID or a tuberculosis history is there. Then I would go ahead and do an hysteroscopy. Not otherwise. Today we monitor them with color Doppler of the endometrium post failure also, and if it is of good zone 3 and above, we don't need to do really hysteroscopy.
So I'd just add one more point here, that in not very we are picking up endometritis and tuberculosis. So I think I would say if a patient has had a couple of failures, at least an endometrial biopsy, if not a hysteroscopy, because we are picking up endometritis, we are picking up tuberculosis, subclinical.
But I said only if there is some past history of infection or tuberculosis.
I wouldn't mind going ahead. In fact, I don't do IVF unless I've done a hysteroscopy on my patient.
We'll take one last question from Dr. Sushila Rani. She has posted.
Yeah, the question is not related to this topic, but anyway, in a patient with infertility, what is the maximum number of submucous fibroids if they were on the opposite walls that you would remove hysteroscopically? For example, a small figo fibroid which are less than 2-3 centimeters. What is your choice?
All of them.
You should remove whatever is possible and then monitor them later on with the sonography with the adhesions. Adhesions are the only problem which occurs in opposite wall fibroids. You can remove it if you're very much within the fluid deficit criteria. You can go ahead and remove whatever number of fibroids you can.
And Dr. Atul, the questions keep on coming. I think we'll stop with this question. Does every subseptate uterus need a resection if there is no previous pregnancy losses? Still, you would resect a subseptate uterus?
Of course not. How many times have we delivered breech and transverse lines and we've seen that the patient?
Sir, you don't need to do.
Okay, fine.
Absolutely not.
Thank you very much. And that was a lovely lecture by all the three of you, and lovely discussion by three of you. And thank you very much, Dr. Vanitha, Dr. Atul, and Dr. Krishna Kumar. It was wonderful having you here. And to the participants here and the other gentlemen and women here, we have to know that we have a parallel program going on in Kerala, the All Kerala Federation, and many of our speakers and delegates have been attending that conference. So the parallel program, the ICOG Masterclass, is running without any hitch, because we run the program every third Friday, and we don't intend to change that, whatever may be the program. With Dr. Lakshmi's perseverance, we are running it very well. And with that program going on in Kerala, we have got absolutely brilliant speakers, and you could see the way the lecturers do their fantastic job here. And thank you very much, all three of you. You've done a fantastic job, and I thank the three chairpersons who've been very patient in conducting the session also. Thank you very much. We close session 1, and now we move on to session 2. Let me share my screen to say the.
Congratulations to the ICOG team. Thanks for having us here in this academy.
Sorry for the mishap. I just completely thought it was 6 o'clock. Thank you very much.
Yeah, thank you all the speakers and chairpersons of session 1. Thank you.
Thank you. We go on to the second session of the ICOG Masterclass, and let me introduce the three chairpersons. And the first one of them is Dr. Hafizur, who's already here. Dr. Hafizur is a professor of obstetrics and gynecology at Sikkim Manipal Institute of Medical Science at Gangtok, India, sitting in the eastern border of India. And he is a very active member of the ICOG with a lot of kudos here. And I'm sure the other chairpersons are joining us fast. Dr. Sarita Balerao from Mumbai, from the Wadia Maternity Hospital, and a governing council member of ICOG, whom we've been hearing as the anchor for any of the ICOG programs, and past president of the AMWI Mumbai, and I'm sure she's going to join with us very soon. And of course, the third chairperson would be Dr. Professor Vidya Tobi from Bijapur, and she's the Kasoga President-elect 2022 and a very active governing council member of ICOG. And with that, let me hand over the sessions to Dr. Hafizur, who's here. Over to you, Dr. Hafizur.
Thank you, sir. I would like to thank you, our ICOG chairperson, Lakshmi Madam, and all the vice chairperson, Dr. Parag Bin, and all the governing council members. So as we are doing, I am very sure this masterclass is going to be very much helpful for all the practitioners in the obstetrics and gynecology laparoscopy, and we have been so many galaxy of speakers, and they are an expert. So the first speaker is our none other than Dr. Kurian Joseph, sir. And we know everyone him that he's a very senior obstetrician gynecologist as an endoscopic surgeon, and he's a director of Joseph Hospital. So we know lots of about his skill as well as expertise. We keep on watching him and many laparoscopic surgeons. And since I have been a postgraduate student, I observed sir in the many operating in the many endoscopy workshop. So sir is the past president on IOFOG and board member of ISGE, and was vice president of FOGSI also. He has been training in endoscopic surgery to many of us are getting, and I am sure today this important topic, which is an integral for doing a laparoscopic hysterectomy, that is in bladder dissection at laparoscopic hysterectomy. And I'm sure sir is going to give us some very important tips as well as some guidance which will clear our knowledge as well as improve the confidence of all the gynecologists, those who are doing or already doing or those are thinking to do. Over to you, sir, Kurian Joseph, sir.
Dr. Kurian is just logging in. He's got
Yes,
some
sir.
troubles. I just opened him 2 minutes back. He's already on the computer.
Yeah. Palani,
Yes, sir, I joined.
Yeah.
He's
Welcome, Dr. Kurian.
Thank you. Just give me a minute, please.
Yeah, sure.
I think we need to stop this sharing to Kurian sir to share his screen.
Yeah, Palani has to stop. Yes.
Okay. Can I share a screen?
Yes, sir.
Yes, sir, please.
Thank you. Can you see my screen?
Yes.
Okay. Just tell me if the video is coming all right or not, because
It's not in slideshow yet.
yeah, I'll do that. Moment. Okay.
No.
Okay. Let's see if the slide moves.
No. I mean, it is not in slideshow.
Click on play, sir.
Moving, yeah.
I put play already.
Play.
Now?
No.
Not moving?
No.
Slide is not moving. Oh,
No, they are not moving, sir.
okay, let me just go back, then I'll have to just get out of this again. Sorry. I'm just stopping the share now.
Yeah.
And
Sir, take your time, sir. We are ahead of time. No issues, sir.
yeah, you're very much before time. That's what I'm getting stuck here.
No, sir, the discussion was very, it went on very well. The speakers finished exactly on time, and so we are.
No problem. Right. Now they said I must do something. Now something I have to do on this. Anything else you can advise me what to do? Okay, let me just do one thing. I'm going to open the presentation fully and then try and share it in.
Yes, sir.
Okay. Moment. Something I had to do last time, which I just want to.
Vanita, meantime, can you answer? There is one question in the chat box related to hysteroscopy.
Yes, ma'am. And I know the question, ma'am.
I will.
Yeah, the question is.
After hysteroscopic surgery, especially septate uterus, does relook hysteroscopy is routine?
After all hysteroscopic septal resections, a relook is not mandatory. You can look for adhesions on a good ultrasound itself. If you have a suspicion of an adhesion, then maybe you could take up.
Sir, they are moving now. Your videos are playing.
For a relook hysteroscopy.
Then I'm ready.
Yes,
sir. Thank you very much. Okay.
Yeah, Vanita, you can take this question after sir's talk is over. Yeah.
No, Vanita is very good at talking here. Let her talk.
No, we told him to meantime just engage the audience by answering questions.
Sorry for the delay. I'm in a hotel at Kollam. Okay. Greetings from Chennai, although I'm from Kollam. You can hear me?
Yes, sir.
Okay, lovely. So thanks to the ICOG team, especially Palniappan, for giving me the invitation. I'm going to basically talk on bladder dissection at lap hysterectomy, tips and tricks. And let's just start with some normal bladder dissection. This is a simple case which I've done nearly about 15 years ago, where we
can't see your slides. Sir.
Presentation, it has gone down.
Oh, it's gone. You said
Please share it again.
You said you saw my presentation?
Yeah.
It was there, but it's not there again.
We saw.
Then what do I do now?
So please share it again. I think.
You want me to share it again?
Yes. Sir.
Done. Oh, the share screen has gone off, right?
Yeah, we can see, sir.
Yes, sir.
No, you can see pictures, but you have to see the.
Yes.
You have to see the slide play. Can you see it?
And video.
The slideshow?
No.
Not yet. So last time it was fine. Just a little while ago it was fine.
Don't know. Okay, it's full now. I'll try again to share screen. Very moody.
Yeah, it is slideshow.
Is it playing?
Yeah, it is playing.
It is playing.
Yeah.
It is playing, sir.
Okay. So this is a video which I've taken nearly about 15 years ago using simple monopolar cautery. I'm separating the bladder. So I'm lifting up the utrovesical fold of peritoneum and slowly cutting it. You can see how clean and simple the cut is. But what I want you to appreciate is the the layers of the utrovesical fold of peritoneum and the loose areolar tissue, which is below that. So once you can see that clearly, you can see your plane of dissection so beautifully. This is what I want you to appreciate. Now, once you see this, you know straight away that this region, there's the bladder. Here you just have connective tissue, and below that is the uterus. Palni, just tell me if you can't see it. Huh? Sorry. Okay. So this is the picture. Yeah. So I'm slowly easing the bladder up. And as the bladder goes up, you can see what I'm left with is only the uterine artery. So all I have to do is to coagulate and cut the uterine artery. But that's not part of my talk now. By way of completion of the same case, I've put a tube to distend the vagina. Once I've distended the vagina, you can see this is the vagina. I'm trying to take off the last few fibers here and making sure that the bladder has gone up completely. So once I've moved the fibers up, you can see that I'm using a monopolar again, and I'm cutting on the tube. So as I cut on the tube, you can see clearly that the bladder has moved up fully. That is the vagina, that's the cervix, and I'm opening the rest of it. So stage by stage, slowly, step by step, I'm using quite old instruments here, quite an old video, but I just want you to appreciate that if you do it like this, your planes are seen so beautifully that you can sit and operate very well without causing any damage to the bladder. So this is the picture for a simple hysterectomy in a patient who had a fairly large uterus. I finished, separated the vault here. Once I finished separating the vault, you can see that, stop the little bleeding there, and then I will take the specimen out and close the vaginal wall. So this is highlighting the normal bladder dissection. This is the completed picture on the same patient. So now I go to the next part of the story, which is for a large fibroid uterus. Here, remember that if you keep upward traction of the uterus, your dissection becomes much easier. So in a large fibroid uterus, again, I'm doing the upper pedicles here. Once I've finished the upper pedicles, I go to the utrovesical fold of peritoneum. This is a fairly large uterus, around 16 week size with multiple fibroids. So I'm carefully, again, here I'm using the ultrasound scalpel, cutting and going down. Lift up, cut the peritoneum and go down. Again, you can appreciate the plane. You can appreciate the loose tissue which is just below the peritoneum. And this is highlighted by the carbon dioxide which we use for insufflation. So as you see the plane so clearly, I just have to push. You can see how beautifully avascular it is. And the trick here is the entire uterus is pushed towards the fundus. I mean, towards the upward. So there's the plane. As I've generated the plane, I will go down further. You can see now how I've been able to get the uterus, the bladder down quite clearly. So this is the second one, which I'm doing in a larger uterus. So step by step, I'll try and take you to the more difficult ones. So once I've done that, I'm coagulating, cutting the uterine artery, going to the other side, again coagulating and cutting the upper pedicles on the other side. then connecting the peritoneum on both sides together, making sure that that bladder has gone down well. So once the bladder has gone down, we get the uterine artery on the opposite side also. So you can see that dissection is quite simple. And then I've put the tube in the vagina. Once the tube is in the vagina, here I'm using the ultrasound scalpel, cutting open. You can see how clearly the plane comes. There is absolutely no room for doubt. And what bleeding you're seeing is the real-time bleeding that's happening. That's all that happens. Again, so with the larger uterus, we have dissected and taken out the uterus. Okay? So that's the bladder. In another case, that's a fairly large uterus. We have taken it out and closed the vault. So then we go to the next part. So your principles of dissection, grab the bladder tissue. I showed you the bladder tissue. Full thickness in the middle. Use an atraumatic forceps. See the stretch on the attachment to the uterus. If the margin is clearly seen, cut across and release it. If not clearly seen, free from one corner, enter the space below the peritoneum and open the lateral window. In very dense adhesions, however, the bladder will have to be dissected down using sharp dissection. And here the vaginal tube helps. So that's the principle of dissecting. So throughout, traction, counter-traction, and proceed from the known to the unknown. So this is going to be the principle of the dissection throughout. So now we go using these principles to a patient with previous to LSCS with fibroids. Here she's got some fibrosis, so you'll see how much different the dissection is. So I'm just going past the upper pedicles, you can see it. And then I reach the adhesions which are below. You can see the adhesions, we are freeing it. As we free it, the bladder gets a little more free. And I'm doing the uterine on that side. So this is another principle we follow. When we can see that the bladder is low down and we can see a part of the uterine artery, we like to dissect it out even before the bladder is dissected down. The advantage of that is it puts the bladder on stretch. You can see that the bladder is on stretch and we can slowly, layer by layer, identify and push it. Now, as against the previous cases, here you can see that the layers are hardly seen. And once it is like that, I can go ahead and dissect out the bladder. So I've gone right across to the other side, dissected free, and now you can see I'm getting to a plane which is similar to what was happening in the normal, but that is only laterally. Whereas in the midline, it's very densely adherent. So here again, I've put it on stretch. That is the uterus. I've identified the plane and I'm carefully dissecting the rest of the bladder off. You can see that this patient has had a lot of fibrosis. So we had to do almost layer by layer and take it down. So this is another aspect. So this is the issue with previous cesareans. So then I find the rest of the uterine artery, coagulate it, cut it, go to the other side, do the same dissection on the other side. And once we have got to the uterine artery, I can go down. I've put the tube in now, and you can see that this is the remnant of the bladder tissue. There is still something stuck to the bladder, the uterus here, and I'm picking up those few fibers. Again, putting it on traction. Once I put the fibers on traction, I can see the loose connective tissue below, cut on that, and slowly my end point is actually to push it up so that I'm sure that there is no more bladder tissue sitting down. So in this, the use of a tube vaginally helps my dissection a lot. So you can see there's a lot of adhesions in this patient, unlike the other case. So you can see it nice and clear. And as we go this side, free the adhesions And then on the other side, also free the adhesions. Once I've freed these adhesions, then I'm happy. I can go ahead now and cut open the wall. So before cutting open the wall, again, we have to verify that there is no other bladder tissue there. You can see above the retracted tissue is the bladder. There is no bladder here, but still I will not take a chance. I will identify that there is no tissue there and cut on it and make sure that I'm getting into the plane. So can you see that? So with that, we go and cut, enter into the vagina again, go ahead and cut the entire vagina, I mean the cervix off from the uterus, from the vagina. So this whole thing is again with the ultrasound scalpel. The other way we use it is also using the bipolar shearer. But for shortage of time, I'm not showing you the use of the bipolar shearer here because I'm sure many of you are very familiar with that. So that's the uterus which has come out fully. So once that is done, then close the wall and come out. So that principle is complete. Let's go further. This is a patient with a lot of adhesions on the left side in addition to the previous two cesareans. So here you can see my main issue is to try and free the left side, whereas the right side is quite free of adhesions. So these are adhesions above the utrovesical fold. And so as I keep going through it, I'll take you a little faster through that. You can get to see the dissection becomes nice and clear. So the principles, as I said, lift up the bladder tissue, identify it, and dissect it off the surface of the uterus. So that's the uterine artery being done. Okay. And once the uterine artery is done, we go and follow the next part of the story. So basic principle, visualize, tissue, dissect. And if your target is not possible, adjust it so that it looks out better. So now we're getting a little more complicated. Take the case of the previous 3 LSCs with fibroids. So here we have a picture where the whole uterus stuck on the anterior abdominal wall. Uterus is big, omental adhesions, and multiple fibroids on the surface. So in this case, we are going to go, you can see as we continue the dissection, I pick up the omentum, adhesions, free the adhesions, take it down, and then work on the anterior surface of the uterus. Uterus is adherent to the anterior abdominal wall. Some people call it a ventrofixed uterus, or whatever you call it, does not matter. So you can see I'm trying to get the plane between the anterior abdominal wall and the adhesions. I'm also trying to take care to see. You can see that there is some adenomyosis because that's that brown chocolatey fluid which comes. So we are continuing to free it. And as we free it, you can see none of the usual landmarks are available. So I've dissected down and I think I'm getting close to the region of the bladder. And as I free it, you can see how dense the adhesions are. So with these dense adhesions, I dissected free. I use a myoma spiral here to pull the uterus up more. I think I'm getting a plane. I'm happy over that. And as I dissect it down, you can see that I'm still not getting into what I want. So there is a bulge there. Is that the bladder or not? Again, I dissect down. So these are the gray zones where with multiple cesareans, your lateral window technique may not work, and one has to straight away approach and treat this problem. So I've dissected the adhesions, and there is a bulge in the center for which now we will go ahead and try and free. So I'm freeing the upper pedicles here. I tried to get the bladder off, but that did not work. So once I free it, I reach down and I think I'm getting to the uterine. So uterine artery is coagulated, cut, and I think I've got a plane where I can get the bladder off. So that's the same dissection on the other side. We'll skip that. And you can see at this level, I think I've taken it down, but what I've taken down does not really satisfy me. It is still a mass of adhesions. So you can see there's a bulge here. I don't know whether that's the bladder. There is another bulge here. There is a bulge here. I don't know whether that's the cervix. But anyway, to try and simplify matter, I go and decide to take off this upper part. So I cut across it, take it, and once I take it, I see that there is still this bulge here. You can see what I've done. I've really not achieved very much. The bladder tissue is still stuck. The uterine tissue is still stuck below that. So all we can do is to just try, take it down a little bit more. And once we have done that, then we can go ahead and you can see that's just a fibroid and the whole cervix is stuck below that. So these are the problems when you dissect out the bladder. So now the anatomy is clearer. I know I can dissect in this plane, push the bladder and remove the cervix out. So for that, I've gone down here again, and you can see that same portion. Before going anteriorly, I'm just cutting the uterosacrals. Remember, whenever you cut the uterosacral ligaments, the whole tissue becomes a little more mobile. And then I can see the anterior plane. I could not see it earlier when I was dissecting. So can you see now there is a plane coming up and things are improving. And because she had previous 3 cesareans, one could really not even reach the cervix from below. So that's the tube which has come in. Once the tube comes in, we coagulate, cut, and remove the whole stump. So that's the stump of the vagina, which of the cervix, which I had done. I'd done like a subtotal earlier, but we don't believe in doing subtotals anymore. So I'm cutting it, taking it, and separating it. So these are the problems you face. You saw the adhesions, you saw the pathology, and you saw the difficulty in taking it. So this is the completion of that same case. We have finished the whole dissection, close the vault, check the ureters as a routine, and then come out. So your tips to success: first, visualize well with a clean field. Second, keep the tissue under stretch. You saw me seeing and cutting. The ultrasound scalpel or monopolar or bipolar scissors, or if you're using the the bipolar shearer, remember the most important is you. You must know where you are and only then you can dissect. If uterine vessels are seen clearly and seen easily, coagulate and cut the uterosacral ligament. If in doubt, at the end of the procedure, put a cystoscope in, see if the bladder is intact, and come out. You have alternate options. There is an entity called reverse vesicouterine fold dissection for laparoscopic hysterectomy after prior cesarean deliveries. This was popularized by Kamran Nezar, but it takes you through, basically dissect it straight from the anterior cave of Retzius region, push the bladder down, and then dissect. It's a little difficult. More interesting is the technique which I saw our Indian friends, Purohit and Sharma, have demonstrated. You can go down vaginally, put your finger, identify the adhesions, cut it, and then try and either take it out laparoscopically or vaginally. Another option is the posterior approach, as I showed you, after cutting the uterosacrals coming around. So basically, it's a time to think. Any questions on this? So this is a TLH where something went wrong. You can see that I'm doing the round ligaments. After doing the round ligaments, this was a straightforward TLH for a fibroid uterus. I have become overconfident, and I think I'm cutting. Normally, this is where we cut. You can see I've become very smart at this time, and I'm cutting higher up. So when I cut higher up, I tend to get a little disoriented. So do I do it from here or here? I take the more crazy thing and then do it higher up. So as I cut, one no, right. So this is the bladder which I've opened. You can see. So I come back, don't get worried. It's not the end of the world. We have to just go further back, dissect the entire bladder off. As I dissect the bladder off, you can see now the correct plane. All I need have done is dissect there. At the end of it, the hole in the bladder is there. The vaginal opening is below. We just have to pick up, identify, and suture the bladder opening in 2 layers. Once we do it, the important message is to leave the catheter for at least 10 days. Luckily, most of the injury you create to the bladder in this picture is at the dome, and it can be sutured very well. So this is the picture. So we could have prevented it with care. So there are many ways to do a laparoscopic hysterectomy. Choose well. Like the tree, you can see a woman with a pot of water, 3 women all carrying it in different ways. Like that, you can do your laparoscopic hysterectomy different ways. But like them, see that you do your work well. Many times life is like this picture. You have the resources, but you make poor decisions. So simplify the trick. The simple trick, learn to identify the bladder tissue. Happy dissecting, and thank you very much.
Thank you so much, sir. That was a very starting from very simple to very extensive as well as complicated case. So I am sure all of us has been very beneficial with this your every step or every cases, and this will give lots of experience or lots of learning points for all of us. So that was a very extensive presentation, and I am sure it will be helpful. So any question, I am sure there will be questions, sir. We would like to take the question at the end.
Okay, fine.
Yes, sir. So we'd like to, is Vidya Thami madam is there?
Yes, she's there. She's there.
Vidya madam, over to you, please.
No, Vidya is not there. Dr. Sarita.
I want to mean, sir,
Dr. Sarita Balera was there.
Sarita ma'am is Sarita Balera madam. I think
Palani, you proceed. You introduce the speaker.
Yeah. So we have again another important topic, that is laparoscopic adhesiolysis during endometriosis surgery. And endometriosis is so common. So we will have this topic by another expert, that is Dr. Paran Kotwala. And sir is a very endoscopic surgeon. He actually doesn't need introduction, but still I am saying that is for the just the formalities. He's a very endoscopic surgeon and consultant gynecologist, and he's vice chairman of ICOG is there, but his chairperson for ICOG is elect. So without any wasting time, we are waiting to hear from Parul Kotwala sir. So over to you, Parul sir.
Sorry, I was trying to introduce Dr. Parul, but they were not allowing me to unmute. So thank you, Dr. Hafizur, for doing the needful.
Ma'am, you can tell a little bit more about Parul, sir?
No. I'd just like to say that Dr. Parul Kotwala is a very experienced and a really very good endoscopic surgeon, and I have seen him, heard him and seen him in many conferences.
Yes, ma'am. So over to you, Parul, sir.
Komal, speakers or chairpersons को co-host बनाओ.
Yes, done, ma'am. Done, ma'am.
I was also muted, so I couldn't speak. Okay. So I get, hi. So Parag, we meet again in 24 hours. Let us move on to the topic and save time. My topic is endometriosis, adhesions in endometriosis, isn't it?
Yes.
Okay, I hope you can see my slides.
Yes.
Yes, sir.
Yes, very well.
Is it the same which I am supposed to share, or is it this?
Yeah.
Okay. Why is it giving some noises? I don't know.
No,
anyway,
muting. You go on. We'll mute others.
So adhesions is a topic very close to my heart since last 22 years. I was spending a few months in Kiel, Germany for endoscopy training in year 2000. And at that time, because I was sitting idle, I requested the professor to let me work on some topic. And I studied adhesions because there were first human trials of a particular substance to prevent adhesion going on over there. And at that time, I could find 465 cases where adhesions were mentioned. And of this, some 54 had a repeat surgery in course of time. So I could see both the primary surgery as well as the repeat surgery. And based on that, I could find the repeat adhesion formation, new adhesion formation, the type of surgery, and the scoring. I'll share with you all those data as well. So previously, we used to consider peritoneum as just a soft membrane inside the tummy covering the organs, but now peritoneum itself is considered an organ. It is a functional organ, not just a passive organ. We will not go into the other details, but any injury to peritoneum is what leads to adhesions. So whenever there is a damage to peritoneum, the damaged area is covered by fibrinogen, which is a fibrin monomer, which is soluble, which converts into soluble fibrin polymer. And that converts into insoluble fibril polymer by the rinsing tissues at surgery. So this is where we have to think a little bit. This insoluble polymer plus proteins make it fibrinectin. And this matrix gets invaded by leukocytes, erythrocytes, platelets, and surgical debris. And this famous picture is posted everywhere whenever adhesions are considered. So either this gets absorbed and cleared up, or it gets organized and ends up in an adhesion. And the data tells us that almost 70% people who have any surgery on peritoneum will have adhesions. And generally, within 72 hours, fibrinolysis takes place and reepithelialization is complete within 3 to 5 days. And that is why the thought process of avoiding suturing the peritoneum came up, because suturing itself may lead to adhesion formation. So these are various studies which have shown the incidence, which is very high, of adhesion in any abdominal surgery. And funnily, only less than 10% gynecologists routinely inform their patient about the risks of adhesion. This was a data surveyed in UK, and I am sure in India also it is the same. We have to inform about these risks before abdominal surgery. Otherwise, sometimes medical legal claims can happen. So this was the paper which was subsequently published in laparoscopic surgery. And what we found was we had 70% incidence of adhesions when a laparoscopy was performed within 6 to 8 weeks following the primary surgery. And of 44 cases where we could see again, 24 had adhesions, 20 had significant, and 4 had flimsy and mild adhesion, 10 had no adhesions. And interestingly, when adhesiolysis was performed, 24% had more adhesions than what was there before in the primary surgery. 57% had same severity of adhesion, and 19% had less adhesion. And all cases of endometriosis had increased adhesion on repeat surgery. So mind you, if there is an adhesion at endometriosis, if it is altering the anatomy or if it is causing a lot of pain, then only touch them. Otherwise, you may end up with more adhesion than what was before, and a fresh symptom may come up. And interestingly, surgery on fallopian tube has minimal adhesion formation. So amongst pelvic organs, ovary is the most risky organ to touch because it leads to more adhesion, and endometriosis even more. Uterus is next, and least adhesion formation in tubal surgery. Now, issues are two: pain and infertility in OBGYN. So pain is generally chronic, related to a particular activity, and it may lead to weight loss if bowel are also involved. Even otherwise, pain may lead to loss of appetite. And in infertility, either tubo-ovarian relationship is disturbed or there is dyspareunia. So pain is significant. Almost 40% of patients with adhesion would have pain. And various studies have shown different incidents. But interestingly, some recent data have given us one interesting aside, that in adhesions, there is a sensory nerve fiber. So it is not just that it is pulling onto an organ and causing pain, but the sensory nerve fibers are there within the adhesion tissue, and that also is a cause of pain. So if there is pain, we have to take care of these adhesions. Infertility, significant association, almost 40% of female fertility is attributed to endometriosis. Now, question is, how do we diagnose adhesion? So we have to be adhesion-minded. And if in endometriosis, if you perform CA125, we now have accepted that it has very less clinical value. But one paper has at least suggested that whenever CA125 is more than 65 units, then adhesion formation rate is much higher. So that would be some indication, if high CA125 is there, that you will be dealing with a case with more adhesions. Adhesions can be filmy like this, or it can be vascular like this, or it can be dense like this, which are cohesive. There is no intervening tissue at all. Now, how do we reduce adhesion? So we can improve our surgical technique, optimize laparoscopy condition. We can use agents targeted at inflammatory response and fibrin deposition, or use barriers. Now, minimizing tissue ischemia by minimal sutures without tension, or micro sutures. When you pull, it may break, so it will be always loose. Free peritoneal or omental grafts are contraindicated because they are very high chance of adhesion weakness. Precise hemostasis and topical hemostatics do not increase adhesions. So we can use Surgicel for hemostasis, does not lead to high adhesions. But one interesting fact I would like to share is exposure of peritoneal mesothelial cells to saline results in reduction of their viability and in loss of their fibrinolytic activity. And so saline, whenever we use as irrigation or ringalactate, it can increase adhesion formation. So peritoneal dialysis fluid with low glucose degradation product is the optimal solution, causing least damage to the mesothelial cells, and therefore may be ideal for rinsing the abdominal cavity. So this is one point which I think will make a difference to our practice. We all know that foreign bodies do lead to more adhesion formation. It is more in open surgery because of powder from gloves, lint from packs, drapes and gowns, wood fibers from disposable paper items, and suture materials. Laparoscopy has a benefit of avoiding all this. And so laparoscopy, because it is also a minimally invasive technique, it is going to reduce surgical trauma to peritoneum. But it has some special problems. One is increased abdominal pressure, insufflation gases, and temperature shift. All this may affect peritoneal integrity and its biology. So Trendelenburg position, which leads to pressure on the diaphragm, and the cardiac output reducing, leads to tissue anoxia. So elevation of diaphragm and compression of inferior vena cava leads to reduced visceral blood flow, and this may impact the vitality of tissue. CO2 we prefer because it is non-flammable, colorless, has a higher blood solubility, and it reduces the risk of complication after venous embolism. But this is one paper where it is mentioned about the pneumoperitoneum and its carbon dioxide specific effects. And another one where it leads to peritoneal acidosis. So these two papers have given us some thought we have to take care of. So we should use as minimum pressure as possible and as less head low position as possible. But interesting one paper and two things I can share with you is one, that we generally tend to have lesser EtCO2 with high oxygen concentration for breathing at general anesthesia. But mild hypercapnia is beneficial and should be accepted as a standard of care. So EtCO2 should be 40, around 40 or slightly above 40 rather than 30 to 35, which most of our anesthetists tend to focus on. And another interesting paper has come up, which was given a special prize for a new medical theory. It is intraoperative CO2 insufflation reduces the risk of surgical site infection. And warm CO2 leads to, moist CO2 leads to tissue temperature rise, and that leads to, and CO2 itself would be killing the bacteria. And that is why CO2 is used for this purpose in food packaging business. So this paper was, could CO2 replace antibiotics in surgery? So maybe this also gives us a thought. And subsequently, another paper reviewed 37 articles, 30 RCTs. And it also concluded that while evidence supporting the benefit of using humidified and warm CO2 can be found in literature, a large human RCT may validate this finding. Now, are adhesions tissue specific? I did discuss this, that ovary is the most hazardous organ to operate upon, leading to adhesion. But there are a few other points also: menses, ovulation, pregnancy, cancer, and diabetes. All these have their own issues of adhesion, but we are discussing today endometriosis, so we will not touch upon them. Now, can adhesions be treated? Patient already has adhesion, so either you should remove them, you can stretch them with exercises so that they loosen up and so they do not pull at the tissue and pain part can be tackled, or we can use preventive measures. So a group in Austria has designed various pelvic exercises where pelvic organ stretching takes place, and that loosens up the adhesions and pain part can be taken care of a little bit. So that is one. Then remove the adhesion tissue. I'll share the videos a little bit later. Then all peritoneal pockets. This is a paper published in AAGL journal, that in endometriosis, we do find sometimes peritoneal pockets in pelvis. These pockets should be excised, and that is what the paper suggested. That leads to reduction in reoccurrence of endometriosis. About prevention, you can look up the literature and you will find a variety of things used. I only touched upon ringer, that we should avoid it. I have started using the dialysis solution since then. 3 substances have shown promise in preventing adhesion as adhesion barrier: the oxidized regenerated cellulose, Surgicel, and this is the spray shield. This was the substance which was being tried in Germany when I was there, where it is like araldite. 2 chemicals are loaded in 2 syringes and simultaneously it is thrown, they get mixed and form a gel which prevents the adhesion formation. Gore-Tex is a beautiful interposition membrane, but it is non-absorbable and you may have to remove it subsequently. So this is not so much used in gynecology. And Ceprafilm, again, this has a problem of stiffness. So previously it was only used in open surgery, but now they have made things which can be used laparoscopically also. But Cochrane review has mentioned low quality evidence suggests that Intercede, Gore-Tex and Ceprafil may all be more effective than no treatment in reducing adhesions. But no conclusive evidence comparing these three, because all studies are observational study. There is no comparative study. No evidence that fibrin sheet is more effective than no treatment. And most studies were commercially funded and publication bias could not be ruled out. So in conclusion, I would say that pain and subfertility are the predominant symptoms in patient having intra-abdominal adhesions. Adhesion formation after primary laparoscopic surgery is quite common. Adhesion reformation is very likely. Quality of surgery is the best adhesion prevention strategy. Surgery on fallopian tubes result in relatively lesser adhesions. Mild hypercarbia with slightly higher EtCO2 may be beneficial in benign surgery. Of course, in cancer, it may increase the chances of metastasis, port site metastasis. Warmed humid gas at low abdominal pressure, less than 12 millimeter of mercury at low flow is the best. It may increase chances of metastasis, as I mentioned, and saline and RL are not the best solution for irrigation. I'll share with you the videos, just few posers about adhesion, why some patients develop adhesions and not all. We do not have answers to this. What are the differences between adhesion reformation and new adhesion formation? We still do not know structurally what is the difference. What are different potentials for adhesion formation in general surgery, pelvic surgery, infection, endometriosis, and ovulation? Again, we are not yet sure what happens. There is now something called International Adhesion Society as well. And because of that paper which we published, I'm also their India region coordinator. Let me share with you the videos now. Okay. So in endometriosis, you will find sometimes very flimsy adhesions, but they alter the tubo-ovarian relationship. One has to be very careful in dissecting them and not producing tissue anoxia or ischemia. Slowly and carefully, we keep dissecting. And as you can see, initially it looked just simple, but we keep on dissecting and a lot of adhesions are seen. And gradually you clear them all. And then we put Intercede. This is, you can wrap it around or at least you can interpose it from the pelvic peritoneum so that new adhesions do not get formed. Now, this case, you can see there are flimsy adhesions. So one may feel what is wrong, you just push them aside, it will break. Not a good thing. What you need to do is cut at both the ends and take out this, because adhesions are bad tissues. If you leave behind adhesion tissue, repeat adhesion will form and which will be denser. So slowly and carefully cut at one end and then cut at the other end. It may, you may feel a little bit tedious about this, but this precise removal will help your patients. So on this side, it looks like all flimsy adhesion, but you can see so many of them are there. And this will definitely alter the tubal motility and ovum pickup process. So in addition to endometriosis toxicity of peritoneal fluid, the anatomical issues may also impact the fertility in this case. So this is on this side. As you can see, new additions, you keep on finding them. Once you remove one set, you find other one. On the other side, similar kind of additions. And then at the base, you can see the ovary is densely adherent. So you have to get it free also. So in endometriosis, especially surface variety, you may find flimsy adhesions more, but sometimes on a particular level, you may find plastic adhesions as well. And once this is done, achieve good hemostasis and leave. This is another case where also you are cutting away the adhesion tissue. So Interseed has been the only product which has on large studies shown that it reduces adhesion formation. But let me share with you one of my own case, unmarried girl, chocolate cyst bilateral, a doctor's sister, I operated on her and I did use Interseed, and subsequently she developed pelvic abscess. And when I checked with the company medical director, he said that you should not have any blood in the peritoneal cavity. Now, endometriosis surgery very rarely would be completely bloodless. There would be some oozing if it is an extensive endometriosis. So that is how one has to be little bit careful when you are using Interseed. You want to benefit the patient, but inadvertently you may harm her. And then you take out the ovary and tube so it is not in contact with the pelvic peritoneum. And that is how you prevent the adhesion formation. And you should not have double folded this. And because of peritoneal fluid, it will stick to the tissue. So this is one more substance. Now it has been off the market. It is a Chinese herbal product. One company from Ahmedabad only started importing it and I used it. It is a greenish gel, blue-green gel, which we used to apply on the tissues. Okay, and this is the adhesion in endometriosis, sometimes making it adherent to the ureter. As you can see here, it looks quite clean, but when we started lifting this ovary on the right side, we found that it is adherent to the base of the broad ligament. And then once we started dissecting, that is one locus, it had 3 locules of endometriosis. And now we know that most endometriosis are multilocular. Very few are, and here you can see that is the ureter. So always keep lifting your endometriotic foci and look behind and then only operate. Sometimes inadvertent damage to ureter can happen. Now ureter has fallen away, it is here. And so you are in a safe zone. But primarily, when you are not seeing the lateral wall, this is another locule. And there was one more. And this is the end result. And you can see the ureter here. There it is. So ureter is one of the most common organ to be damaged by the endometriosis if it gets adherent to that. And of course, the rectovaginal nodule is another. Here it is a plastic adhesion. It is very difficult. You have to cut between the tissues very carefully. And sometimes one can cut towards the ovary, little bit of ovarian tissue may be left behind towards the rectum. Here bilateral chocolate cyst, surface endometriosis, as well as rectovaginal nodule. You can see there is no intervening tissue. And this is where, this is the area where the nodule is there. And here is the rectum. So you lift it up above the rectum, and then it has to be a sharp dissection. It may look messy, but the bleeding generally is reduced once the surgery is done. This has a very typical rubbery feel. Once you feel it, you will never forget it. Even while cutting, that feel is very distinct. And then, since the vagina got open, we use that area to take out the tissue, both the nodule as well as the cyst, and then close the vagina. So this is how the adhesions can come up and lead to various different issues in endometriosis. I think I have just finished my presentation in time. Balani, am I in time?
Yeah, you are.
Yes, very much in time.
Okay, thank you very much.
Sarita madam, you're there. Sarita Bhadram.
Thank you very much, Dr. Parul. That was absolutely brilliant, and that was exactly what we wanted out of you, the tips and tricks of dissecting adhesions. Yeah, Dr. Sarita, you can start.
Yes, Sarita madam, over to you. Please unmute, madam. Host, can you?
Okay.
Yes,
Yeah,
sir.
thank you, Doctor. Thank you,
Yes.
Dr. Parul, for that excellent talk. And it was really very informative. And I'm interested that you had a pelvic abscess following that interseed, because I think it's a very rare occurrence. I really think that there's not much thing. Should we move to any questions, or should we move to the next speaker?
Question at the end.
Next speaker, questions at the end.
Okay.
Next talk, Sarita. Yeah.
Okay, I'd like to now introduce our next speaker, and our next speaker is none other than Dr. P.G. Paul. Dr. P.G. Paul is a well-known endoscopic surgeon from Paul's Hospital in Kochi, and I've been very fortunate to visit his center and train with him for 2 weeks, and I really learned a lot from his center. He's also an authority on endometriosis and has a lot of work on that subject. He's a board member of the International Society of Gynaecological and an elected member of the Society of Reproductive Surgeons of ASRM. He has authored many books. He's given hands-on training to more than 1,800 gynecologists, and he's received the Lifetime Endoscopy Empowerment Award by the IAGE. He's also by temperament a very, very relaxed surgeon, which I think is something that I admire him tremendously for. He never gets unnerved, and he's always very calm and very cool.
To add, so Dr. Sarita, just like how we have 2 tubes, I don't know whether he will recanalize 2 tubes or not. He's attending 2 sessions at the same time, and Dr. Kurian and Dr. Paul are in Kollam attending the All Kerala Federation of Obstetricians and Gynecologists physically, and they are attending this ICOG Masterclass online. And so it's indeed very nice of both of them, Dr. Kurian and Dr. Paul, to have accepted this invitation and be here and enlighten us on this topic. Over to you, Dr. Paul.
Thank you, Palniappan, and thank you, Dr. Sarita, for the kind introduction. And I am asked to speak on tubal surgeries. Probably I have done many lectures on this. Because of repetition, it's a little boring to me. But anyway, I think I will share my experience on tubal surgery. Can I share my screen?
Yes, sir. Komal, have you made him co-host? Yeah.
Yes, ma'am. Done, ma'am.
Can you see my slide?
Yes, sir. Very clear. Yeah.
Oh, okay. Oh, my last slide has become first. Pen has given me a very good caption and effects. I am still to understand what exactly it means. Yeah, that is because of my my laptop has slight problem about the position of the camera.
It's perfect, sir, but
Okay.
yeah.
I'm going to speak on reversal of sterilization because that's one of the tubal surgery which is still practiced. And the indication for reversal is still there because globally so many million women are being sterilized by tubal sterilization by rings or similar methods. And all of us know that 10% of them may regret and 1 to 3% may seek tubal reanastomosis. The most common reason in our practice is either loss of their child or remarriage, or sometimes they come for additional, and very few come for religious reasons also. All of us know that now we have availability of IVF all over the country, even in small towns. So you have both options, IVF and tubal reversal. And many think that they try to use us like a Maslow hammer, where you are good at, you tend to advise the patient to undergo. As far as fertile women are concerned, you have good success with both. And tubal anastomosis has certain advantages, obvious advantages like that. It's a one-time procedure, then they can conceive naturally, and they can still try more than one children. I started tubal surgery, tubal anastomosis, I think 98, 99, with standard laparoscopic procedure, standard 2D laparoscopy. And it was a little struggle with the 2D. And when we changed out to 3D laparoscopy, the tubal anastomosis, that fine tuning was comparatively easier with fine sutures. Now, those who are access to robotic, they use it very comfortably. I don't have any experience. I still use 3D for my tubal anastomosis. 3D has this advantage. You have a 2 lens system or 2 camera systems. So it have a binocular vision. And many people, my juniors, I find that they use tubal anastomosis with the regular 5mm instruments. I'm a bit unhappy because when you use a 5mm instrument to see a 1mm lumen, I don't think you have a good vision, and precise microsurgical techniques has to be practiced. Then you need smaller instrumentation, smaller needle, fine sutures. So apart from the Procas for 3mm instruments, we need a 3mm grasper, and you should have a good grasper because most of the commercially available ones, when you use it on a 6-0 or 7-0, it damages the suture material and then they break when you tie, which is very unpleasant for the surgeon. You need a needle holder and a grasper, the 2 main instruments for tubal anastomosis. This is a chromoperturbator. I'll show you in the video, which you can use it to size the lumen as well as do chromoperturbation from the proximal side. And whether you use a 3mm scissors, I used to buy this one, but the scissors by Karl Stross and all pretty costly. So I am now using the regular 5mm scissors for cutting the suture. I started with 6-0 proline or ethylone, and you should select a needle which penetrate the tissue without counter pressure. So always buy the CV needles are available. Can you see that? 70 centimeter CV, cardiovascular. The cardiovascular needles are slightly better because if you hold on the tubal musculature and try to penetrate, it normally traumatizes. So just by counter pressure, it should be able to penetrate. So select a needle which penetrate tissue without counter pressure. And I have some experience with the barb sutures, which I will show you later. The basic principle of anastomosis is the knot should be outside the lumen. So either side you start from outside in, inside out. Either from the proximal or distal doesn't make any difference.
Hello, Palani, I think he has lost his connection. Hello. Palani, are you there? Sarita, meantime, I think you can take questions, or Hafizur, you can take questions. I think he will have to log in again, Dr. P.G. Paul.
Yes, ma'am.
Yeah. I could see that.
I can see a few questions.
Yeah, so please.
There are some questions on what fluid can be used for irrigation other than RL or NS.
But
I think Parul sir can answer that.
Parul,
yeah, Dr. Parul is there. He can answer. Yeah.
Yes, yes.
No, I did mention that. No, the fluid that they use in peritoneal dialysis, which is the most, you can say, soft fluid for the peritoneum. So it leads to minimum damage to the peritoneum. Saline, if you wash vigorously.
I see Dr. Paul is back. Huh?
Yeah. No, but still.
Sorry, Dr. Kondawala, go ahead. Finish what you are.
Yeah.
No,
Dr.
Yes,
Paul.
ma'am. Done, ma'am. Done, ma'am.
Yes, sir.
Paul,
Yeah.
Paul sir, you are please unmute yours.
Okay, okay.
Yes.
Here we had a electricity problem and temporarily the Wi-Fi got disconnected.
Yeah.
No problems.
This step was visible previously.
Yeah, slides were visible, but now we can't see.
Oh, okay. Sorry. I
have to share again. Yeah.
Is it coming now?
Yeah.
Okay.
Yes, we can see.
I stopped at this point.
Yes, sir.
Yes.
So the principle of suturing is normally we use interrupted sutures, 4 sutures, 6 o'clock, 3 and 9, and finally 12 o'clock. And the knot should be ideally outside the lumen. So you go outside in, inside out. Whether you start from the distal end or proximal end doesn't make any difference. This is a case of reversal of sterilization. The first step is you incise the serosa around 0.5 centimeter from the tip, and you excise at least 0.5 centimeter of the fibrosed proximal end. And meanwhile, you will be doing chromoperturbation to identify the lumen. This is the chromoperturbator. You chromoperturbate from the proximal end. If you do from the distal end, the mucosa will pout out and you will have difficulty in suturing. So I took, this is the mesosalpinx suture. Normally I put a mesosalpinx suture first and then do the anastomosis. But this has to be precisely made. I think I made the 6 o'clock suture first rather than the mesosalpinx. Sometimes, yes. Now we are doing the 9 o'clock suture from distal end to the proximal end. I go through the lumen. Many people ask why you should avoid. Practically impossible to avoid mucosa on the distal end because the muscularis is so thin, and then you make interrupted sutures. You have to put 2 or 3 throws more because it's a very slippery suture. And now I'm doing the 12 o'clock. Some people do 3 o'clock first and then 12 o'clock last. It doesn't make any difference. Ideally, the last 2 sutures should not be tied. And during each bite, I do the chromoperturbation so that the lumen get distended and you can take precise steps. So always take a very diluted methylene blue, otherwise it will stain the whole area. So use a minimum color. I normally tell the sister to
I think he again discussed.
Parul, you can engage the audience. Meanwhile, he can log in again.
You're telling something actually which was not complete.
Yeah, because
any questions that people have posted or not?
There are no questions. There was only one question which Dr. Kurian has answered. Dr. Tabassum has asked what is the hysteroscope I should buy and things like that. Dr. Kurian has answered the question that try the Bitoshi design made by Manju Surgicraft at Mumbai. So far, that's the only question as of now.
So we can invite questions if there is any.
I think we can invite questions, and there are questions. Audience, please put it on the chat box. We can read it and take it while Dr. Paul revisits us.
Yeah, there is somebody who has raised a hand. Yeah. Please, north is 2211.
that is the problem because we can't see. They can, they can start their video on their own so that we can see them.
Okay, Paul is back.
Yes. Meantime, if he logs out again, Parul, there is a question for you. Which energy source you use to release adhesions?
So ideally, no energy source. Cut them with scissors, and if there is bleeding, then only microcoagulation.
Paul sir, please unmute.
Harmonic only if there are contiguous adhesions, like two tissues are plastered with each other, and then you want to dissect in between. Then only harmonic has a role. Otherwise, flimsy adhesions, even vascular adhesions, harmonic doesn't is not required.
Yeah, Paul sir, please.
Okay.
Yeah.
So I finished all 4 sutures, and then finally the seromuscularis, and then check for the chromoperturbation. There can be minimal leak, but if the dye comes, that give you a very consoling surgery, because I have seen that if the dye doesn't come, the results are not really good. So ideally you should get chromoperturbation, but it also, there is a lot of leak at the suture line. Then the problem cannot come, then you can put more additional and then go ahead. There was a time I used to perform tubal anastomosis only on one side. And we tried to find out what's the result. And the results were almost comparable. Only 5% difference was there if you do it on both sides. Now I am back because most of the patients, they are in really need of another child. I perform on both sides if the tubes are okay. These are my old result where we got around 55% of pregnancies. This is little less than the internationally quoted one because we perform tubal anastomosis for every case come to us. Just because it's short or poor prognosis, we don't actually avoid doing this. Then after the barb suture availability and smaller, thinner sutures were available, I thought why not we use barb suture, because knotting is the most critical one, which most of the youngsters find it difficult. So we started using these barb sutures. We know that the quill suture or the Johnson & Johnson suture, they put the size as the uncut portion. So if it is 5-0, they write the effective strength is actually 6-0. Unlike V-lock, they actually put the actual inner size. So there is a size of 1 difference between these two sutures if you say the numbers. This is one of our case. This is my 3D laparoscopy. That's why the picture is 4:3. We normally use a spinal needle for injecting vasopressin into the operating area. Normally, we don't coagulate any bleeder when you transect the tube. Most of the bleeder will stop, but to make the surgery easier or faster, we inject the vasopressin and it is effective. You can see that the serosa and the lumen both are in different levels. If the serosa overlap the mucosa, there will be a lot of struggle in actually taking the bite. The distal side, you must try to tailor the incision size to the proximal size as much as possible. Sometimes it becomes slightly bigger, it's okay, but try to make it smaller, and even if you need, actually you can make it bigger. And we are actually wondering, if you put only one suture, there will be a purse string effect at the site of anastomosis. So we did a little bit of modification. First, we did the mesosalpinx suture with the regular 6-0 proline, because they are wide apart and taking bite may be slightly difficult. So the placement of this mesosalpinx suture is very important, because if it is very close to the tube, then the tubal lumen overlap and you won't get any space to really take good approximating bites. So this is the mesosalpinx suture. Now the two tubes are aligned. You keep away the proline suture. And this quill suture, 5-0 suture, I cut into 2. And each end, I made a knot so that it will remain at this point. Then you take the 6 o'clock suture outside in. Actually, you should have taken little smaller length. It's going through the lumen, and 6 o'clock from inside out. And gently pulled. The final pulling is not done at this point. We are planning to take 2 bites, 6 o'clock and 3 o'clock with the one suture. This is the 3 o'clock one. You can see the chromoperturbation going on so that the lumen will get distended so that you can take the bite. And when you tighten this, you should make sure that there is no purse string effect on the lumen. Just sufficient to approximate. I have not really tightened. Now coming with the second suture for the 9 o'clock and 12 o'clock suture, so that the purse string effect on the lumen will be minimum. If your 6 o'clock space between 6, 3 and 9 is more, most of the dye leaks out, and that can be one reason for the chromoperturbation. There can be a lot of leak at this suture point. Now we are coming at the 12 o'clock. Basically, this needle is designed for skin suture for the plastic surgeon. So they are comparatively thick and not as sharp as the CV needles I mentioned earlier. So on the left side, you have the 9 o'clock and 12 o'clock. I'm gently pulling in, just approximate. It's a visual approximation. Now the 6 and 3 on the right side and gently approximated. And I'm just checking whether our approximation is correct, and you can see that the dye is coming. So that means you have done a reasonable. And with the same suture, the first one I use it for the cirrhosis. This is only for supporting the other sutures, not for really any cosmetic. Ideally, should have made this suture length a little smaller, because pulling the suture through the fine tubal mucosa and all little more traumatic. So that is done. Now the seromuscularis on the left suture, which he used it for 9 o'clock and 12 o'clock. Actually, this was my second case. So we are really worried what will be the results. So in the initial few cases, I did my regular suturing on one side and the barb suture on the other side. Then finally changed over to barb sutures. Even now, I still use the smaller one when the lumen is very small. When the lumen is less than 1 millimeter or 1 millimeter, this barb suture needle is not good enough. So I still use the regular suturing technique. This good anastomosis, actually this patient became pregnant. And nowadays, whenever I have a chance, the lumen is good enough, I use the barb sutures rather than the regular sutures. Little disciplined, otherwise it's comparatively easier. I think this is the first report I have published in the JMIC. This may be the first report on tubal reanastomosis using barb suture. If you look at the literature, the pregnancy rate ranges from 65 to 68 and the tubal pregnancy rate up to 7%. We know ART success rate has improved, but if you take larger data, the ART rate is something like 35%. And the cost analysis and all, just for the sake of argument, they say it's half that of tubal ART. The main prognostic factor is age. Almost majority of the series have shown when it is less than 30 years, the percentage may come to 80, 85. When above 40, 45, the pregnancy rate is still reasonably good, 45%, with a slightly higher miscarriage rate. And the tubal length also makes a difference. Less than 4 centimeter, poor prognosis. If there are associated tubal adhesions, definitely the results are poor. I initially thought ambulatory anastomosis is better because the anastomosis is technically better. And usually the isthmic side, our Indian women, I don't know, the lumen appears comparatively smaller. And we have technical difficulty, but the result shows that the site of anastomosis, isthmosis, is still better. This is an old couple, I think she's 40 or 42. During the tsunami days, I have done this. So to conclude, around 1 to 3% of patients may request reversal of sterilization. ART is an alternative, but it's more stressful. OHSS, more costly. And tubal anastomosis, in good hands, it gives almost good results and more natural as far as the patient is concerned. And you can try more than one pregnancy. But definitely ART has a role when the tubes are very short, there are significant adhesions, other associated endometriosis or male factor. So I want to invite all of you for the next annual AG at Kochi. It's on 17 to 19. 1.5 days live surgery. Surgeries from 7 centers in India and 2 centers, one from Rome, Maria Malsoni, and Passover from Switzerland. So we have a lot of surgeries to watch, a lot of surgeons, different techniques, and then we have a lot of discussions on the next 1.5 days. So thank you all for giving me this opportunity.
Thank you, Paul, sir. That was fantastic. And I'm sure the effects and effects of tubal recanalization is going to last longer in all our brains and minds. And I'm sure there are a lot of questions to go on here. First to Dr. Paul, why don't we use delayed absorbable suture like Vicryl for reanastomosis?
Vicryl is actually very difficult to handle because once it becomes wet, then it's not very easy to handle it. Then the contrast, this proline, that blue color is totally different from the body's color. The Vicryl is almost like body color. And when it's become wet with blood, it's more difficult to handle. And the earlier microsurgery by Victor Gommel and those groups, they have found non-absorbable suture produces less tissue reactions, and they studied and they found it's better. So I followed those principles and continuing the same.
Thank you. And before Dr. Parul goes off, I think he's already answered which energy source would you use to release adhesions, harmonic or scissors. I think he answered scissors. Dr. Parul, would you want to reiterate your fact, why you use scissors over the harmonic scalpel?
See, basically, adhesions have formed because of tissue ischemia. So if you use energy source, you may compound that ischemic damage. So you dissect with scissors. And if there are any bleeders, then only microcoagulate that point with a very point coagulation. Otherwise, the reoccurrence of adhesions are more likely.
Okay, thank you.
And only when tissues are stuck together, then harmonic works well because it simultaneously produces hemostasis.
Okay. Paul, sir, after after recanalization, when would you want to do a HSG, or even if you've seen these spill of dye, when would you repeat HSG or tubal tests for patencies after some time, and when, what?
My majority of my pregnancies usually occur within 9 months in young couple. So previously I used to do it after 1 year. If they still want to try on this or change over to ART, those days ART was not very easily available and very costly. But nowadays I stopped doing HSG because after 1 year they don't conceive. I advise them, you better go for because I have done many hundreds of HSGs, and most of the patients are very unhappy with this HSG. It's a little more painful, and so unless there is a request, I don't do it nowadays.
So when you see a spill of dye through the fibria, you don't follow the tubal patency after that and straight away allow them to become pregnant?
Yes.
Okay, so
I allow them to.
Okay, yeah, thank you. And is there any role for using a steroid? People instill dexamethasone, betamethasone over it, antibiotic, metronidazole, etc. Would you do that after the surgery to prevent adhesions or to keep? No, you don't.
Oh, nothing. I think those days open microsurgeries we used to irrigate with the saline steroid and all. They are all superfluous. It actually depends on how you do the surgery.
Okay, fine. And any tips to suture the ampullary end? You mentioned about the suturing the ampulla. Any tips to suture the ampullary end, and when there is a discrepancy in size between the proximal and distal tubal, and would you use somewhere the ampullary end suturing?
We'll try to avoid a local bulging of the tube. So equidistal sutures I make. So there may be little overlap of the wider lumen over the smaller one. But I don't think it makes a lot of difference.
Thank you, sir. I'm sure Dr. Kurian is with us here. Sir, you did mention about Dr. Kurian?
Yes.
Yeah.
Sir, you did mention about the lateral window or the space of shade where you would go ahead and do. How would you rely more if the additions in the midline is very, very common? So how much have you used the lateral space and gone in because the additions are more common in the midline?
You have to choose. One of the options is to get that space and get below the level of the addition. Now remember, in a previous cesarean, it is close to that scar that all the bladder is adherent. If you go down further, there's an empty space. So if you can go into that empty space, then you can dissect up. But as I showed you in some of those cases, all that doesn't work out. So you have to take case by case. Some of them you may have to go, you can go through a lateral window, push it up. Some of the cases you have to, in fact, one of the people asked me, somebody does it without putting the tube in the vagina. You can very well do it without that, but it's all based on your experience. So when you're starting, get the tube, put it, you see the bladder nicely distended. You see the fornix distended well, and then dissect it off, it works quite well.
Sir, and you did tell about suturing the bladder in 2 layers, if at all incidentally you open and then leave it for 14, leave the CBD Foley's for 14 days. Would you, at some point of time, think about leaving a suprapubic cystostomy, which we used to do 15, 20 years back? And so what is your thought on the urology?
Suprapubic is history. You don't have to waste your time.
Absolutely. So
very inconvenient to maintain it. And those days we didn't, you remember, we never used to get good Foleys.
Yeah.
That was when we had that little bulge with this SPC catheter, which we could put. So no SPC, a regular Foleys. You can put a wider Foleys. If funds are not a problem, you can go for the 3-channel one. So if there are any clots, you can take it out through that also.
Any use of the silicone Foleys rather than the routine Foleys?
Well, all this means money.
Yeah.
So whichever you want, you could go in.
No, for the bladder.
It's definitely cheaper, no doubt about it. More expensive.
More expensive, yes. Paul, sir, always the muzzle layer and serosal layer to be stitched separately, meaning always is anastomosis to be done in 2 layers. Can't we just take it through a single layer and go ahead? Paul, sir?
Yes. The first layer of suturing is the most important one, where you actually have cut the serosa, and serosa is away from the lumen. So whatever tissue is remaining, that you take in the first layer. And once you finish that, rest of the seromuscularis you approximate to reduce the tension at the suture line.
Fine. So meaning always it needs to be done in 2 layers. That's what the doctor
two layers.
Want.
Otherwise it will be very crude, because if the serosa is always hanging over the lumen, you won't be able to make perfect bites.
If there are any other questions, and Dr. Bharat, Dr. Lakshmi Shrikande, I'm sure you would want to end. And exactly, we are on time, and putting on a disclaimer, can I say that we are before time departure, just like what Indigo announces, we are 6:59 and we're supposed to end at 7 with Dr. Lakshmi Shrikande.
No, but Indigo starts also before time.
I said disclaimer. I said disclaimer.
I'm so thankful to Dr. Paul, Dr. Kurian, Dr. Parul, and everyone is here, all the speakers and chairpersons, and Palani, very well designed module for this today's masterclass. Well done.
Thank you. Can we have the recording of Dr. Lakshmi with your permission?
Yes. Komal, please stop recording.
Thanks,
Yes, ma'am. Yes, ma'am.
Thank you, Kurian sir, Paul sir, and Dr. Parul. That was fantastic. And the chairpersons, Dr. Sarita and Dr.